As we talk about the vertebral curvatures, we understand that in the fetal scenario, when the mother is having the baby inside, that is intrauterine life, there is a universal attitude of flexion. The baby is having all the joints folded, may it be the neck region or the upper limb, lower limb region, and also the back. So what you see is there is a dorsal convexity, which is called as the kyphosis. Now that dorsal convexity or kyphosis is going to modify as the baby is born, and as the baby is holding the neck, that is about the 2 month of age, there will be one cervical lordosis coming. You will find that during that neck holding, there is a secondary curvature which is coming, or acquired curvature, and that will have one anterior convexity, which is called as lordosis. So this is the first thing which we notice, that lordosis is coming. Now the baby is sitting and standing, and what happens is that maybe at nearing the age of 10 months to 12 months, it is one more curvature acquired, which is called as the lumbar curvature, and that is also secondary curvature. Now this lumbar lordosis, as you can see, is also one convexity which is anteriorly. Now both of these, maybe cervical or lumbar lordosis, they are acquired curvatures after birth, and they are second degree curvatures, and the primary curvatures which were already present in the fetal life remains in the thoracic region and the sacral region. You will understand that there we have got a thoracic kyphosis and also a sacral kyphosis. So these are the primary curvatures. Now, when a lady becomes pregnant, what happens is that there is a baby coming on the anterior aspect of the body. So center of gravity is shifting anteriorly. So she will be having exaggerated lumbar lordosis there. Here we are going to compare the cervical vertebra with the thoracic vertebra and the lumbar vertebra, and we find that there are some similarities between cervical and the lumbar vertebra which are different from the thoracic. Let us look at the differences and similarities as well. So as I'm suggesting, cervical and lumbar vertebra have some similarity here, and there are some differences from the thoracic vertebra. Let us first look at the similarities between cervical and the lumbar vertebra. They are having the oval-shaped body, and their vertebral canal is triangular. The spinal cord, when it is passing through the vertebral canal, if you take a transverse section of the spinal cord in the cervical region or the lumbar region, you will find that transverse section of spinal cord is triangular, as it has to pass through the vertebral canal there. Now, if you reverse this order and look at the thoracic vertebra, it is the same. You will find the vertebral canal has become oval, and you will find that the body has become triangular or the heart shape. So what you find is that here the bodies are oval and the vertebral canal are triangular. You reverse it and you find that here the vertebral canal has become oval and the body is triangular or heart shape in the thoracic vertebra. If you take a transverse section of spinal cord now in the thoracic region, that will be appearing oval as compared with the triangular appearance in the cervical or the lumbar region. The characteristic feature of cervical vertebra is that it will have foramen transversarium for the passage of the vertebral arteries, and it is seen only in the cervical region, missing from the lumbar vertebra or the thoracic vertebra. It is present in the transverse process of cervical vertebra only. And understand that vertebral artery, which is going to supply the circle of Willis, is passing through the upper 6 cervical vertebra, transverse foramen. Though there are 7 cervical vertebra having the 7 foramen transversarium, but only upper 6 will have the vertebral artery passing through. And to identify the thoracic vertebra, you'll find that in the thorax we have got the ribs. So ribs will be having some costal attachment which is on the transverse process of the thoracic vertebra. So rib facets are present only in the thoracic region and not in the cervical or the lumbar region, because we don't have ribs in the neck or the abdomen region. And how do you know that this is lumbar vertebra? Because in the transverse process I don't find any impression of the ribs, costal facet, or any foramen transversarium. So it becomes lumbar vertebra. Plus you will see that the body of lumbar vertebra is the largest. and the body of the cervical vertebra is the smallest. So much so that the C1 vertebra, atlas vertebra, do not have a body at all. It is missing in the atlas bone. And the thoracic vertebra will be somewhere in the middle, average size of the body, as compared with the cervical or lumbar vertebra. Plus, there is one more feature, that is superior articular facet of the three vertebra. You will see superior articular facet of the cervical vertebra, where it is going to articulate with the upper vertebra, is directed backward and upward, whereas in the thoracic region, the superior articular facet is directed backward, upward, and lateral also. So, as the thoracic vertebra is articulating with the upper vertebra, the superior articular facet is directed backward and upward and lateral also. But if you look at the superior articular facet of the lumbar vertebra, then it is directed medially. So here it is medially directed superior articular facet, there it is laterally directed, and here it is neither lateral nor medial. It is just backward and upward. Now here you find that the spinal cord is passing through the vertebral canal and giving some spinal nerves in the intervertebral foramina at several levels. So here you can see this is the spinal cord, and it is giving spinal nerves at the different levels, and these spinal nerves are coming at the level of intervertebral foramina between the pedicles of the two vertebra, higher vertebra and the lower vertebra. Now you will notice that there is one ligament which keep running anterior to the body of the vertebra, and that is why it is called anterior longitudinal ligament. And there is one ligament keep running on the back of the body of the vertebra, which is called posterior longitudinal ligament. So here is the posterior longitudinal ligament, which is running behind the body of the vertebra. So anterior longitudinal ligament and posterior longitudinal ligament. And behind the posterior longitudinal ligament or the body of the vertebra, you have the vertebral canal. And in the vertebral canal, we have the spinal cord, which is having anterior longitudinal ligament anteriorly. The spinal cord lies in the vertebral canal, and you will find that in front of spinal cord is the body of vertebra, which is having posterior longitudinal ligament, and behind that is the ligament which is connecting the lamina of the vertebra, called as ligamentum flavum posteriorly. So here we have the ligamentum flavum, which is connecting the lamina of the vertebra, higher vertebra to lower vertebra, and that ligamentum flavum is lying posterior to the vertebral canal and also the spinal cord. So spinal cord is basically sandwiched between the posterior longitudinal ligament anteriorly present and the ligamentum flavum present posteriorly. The similar story you can see here also. This is the front view of the vertebral column, and you find the most anterior ligament, which is anterior to the body of the vertebra, is the anterior longitudinal ligament. If you remove it, you find body of the vertebra. If you go behind the body of vertebra, then you have got the posterior longitudinal ligament, which is running behind the body of the vertebra, and behind that will be the vertebral canal containing the spinal cord, and behind the spinal cord will be the ligamentum flavum. That is the ligamentum flavum, which is connecting the lamina of the upper and lower vertebra behind the vertebral canal and the spinal cord. Then you will notice that behind the ligamentum flavum, you have got the spinal vertebra having some spinous ligament, like there is a ligament between the spine. So you will say it is the interspinous ligament. And there is one ligament which is above the spine of the vertebra connecting the spine with each other, that is called as the supraspinous ligament. If you are doing a lumbar puncture, a needle you are taking, the first ligament to puncture is the supraspinous, then you will puncture the interspinous, then you will puncture the ligamentum flavum, and then you can reach the vertebral canal to do the lumbar puncture. And in lumbar puncture, you have to pierce the dura mater and the arachnoid mater, and then you can aspirate the CSF, or you can inject the anesthesia agent as well. So here you can notice that the lumbar puncture needle is piercing the ligaments, which are supraspinous ligament here, and after that you will have the interspinous ligament here, and after that you have the ligamentum flavum more anteriorly here, and it is the last ligament you are going to puncture. When you are piercing through these ligaments, there will be a resistance to your movement of the needle, but as the ligamentum flavum is punctured, there is a sudden loss of the resistance and giving you a popping sensation. You will get to another popping sensation when you have punctured the dura mater as well. Additionally, you can see what is posterior longitudinal ligament running behind the body of the vertebra, and this is the ligament which your needle is not supposed to reach. If it reaches there, it might have been some accidental approach. And still anterior to the body of the vertebra, we have got the anterior longitudinal ligament. Now, when it comes to the yes movement, where the skull is moving on the atlas bone down there, basically at the atlanto-occipital joint, you will find that it is ellipsoid synovial joint, though some books will call it condylar synovial joint as well. Here you involve flexion and the extension of the head over the vertebral column. And when it comes to no movement, we are rotating your head to right and left side. That is where the atlas bone is articulating with the axis, atlantoaxial joint. So the higher joint, which is atlanto-occipital joint, is for the yes movement, nodding movement, whereas the lower joint, which is atlantoaxial joint, is for the no movement, rotatory joint, and it is called as pivot synovial joint or the trochoid synovial joint. Let us look at the joints from the posterior view. This is the skull, which is sitting on the atlas vertebra, the C1 vertebra. So there you have the atlanto-occipital joint, which is for the yes movement or the nodding movement. This is the occipital bone and this is the atlas bone here. And they have the condyles, and this is the condylar synovial joint, but better called as ellipsoid synovial joint. And below that joint is the atlantoaxial joint, where you will see the C1, C2 vertebra are articulating. C2 is the axis bone and the C1 is the atlas bone. So atlantoaxial joint is actually a pivot synovial joint, rotatory trochoid synovial joint for no movement, rotating the head laterally to right side, left side. Now here you notice that the upper bone is the atlas bone, which is the C1 vertebra, and the inferior is the axis C2 vertebra. That is the C2 vertebra, atlantoaxial joint, shown here as well as here. And you will find that the axis bone is giving a projection upward, which is called as the odontoid process of the axis or the dens of the axis, which is articulating with the atlas bone superiorly. And there is one articular process for the dens of the axis, and the dens is held there by a transverse ligament attaching to the atlas bone. You can see it here as well. It is the dens of the axis fitting into the atlas bone, and the atlas bone will have a transverse ligament which is to hold the dens here. This is where you have the rotatory joint or the pivot synovial joint, allowing for the rotation of the head over the vertebral column. Now we want to talk about some ligaments in this area, which is the craniovertebral joint, involving three bones, that is the occipital bone, the atlas, and the axis bone. The most posterior thing we see is called as the nuchal ligament in the neck region, which is the supraspinous ligament modification. Then anteriorly you will notice there is a membrane which is in the region of ligamentum flavus superiorly, and it is connecting the atlas bone with the occipital bone posteriorly. Similarly, there is one anterior atlanto-occipital membrane also, which will be quite anterior, but between the two you have some more ligaments to discuss in the craniovertebral joint. If you go still anterior to this, you will find that the lower medulla oblongata is continuing as the spinal cord in the vertebral canal, and in front of the spinal cord you will find a ligament there, now called as the tectorial membrane. But the tectorial membrane is actually the continuation of the posterior longitudinal ligament behind the body of the vertebra. It changes the name. So tectorial membrane is the continuation of the posterior longitudinal ligament as it enters the foramen magnum to attach to the occipital bone inside. And still anteriorly you will find there is a plus-shaped cruciform ligament, and a part of that is evident here. If you go still more anterior, you'll find that there is apical ligament of the dens. So this arrangement of the ligaments, let us look at that again from posterior to anterior view. The most posterior thing is the supraspinous ligament modified in the neck region to form ligamentum nuchae, which attaches to the spine of the cervical vertebra and also the occipital bone here. And as you see, the ligamentum flavum is continuous above, being replaced by a membrane called as the posterior atlanto-occipital membrane here. Now let us remove these ligaments and go still more deeper. So as we have cut the nuchal ligaments and the posterior atlanto-occipital membrane, we can see the vertebral canal. There you will have the spinal cord, which we have removed, and in front of the spinal cord you have a ligament which is called as the posterior longitudinal ligament behind the body of the vertebra, but as it enters the foramen magnum, it will be renamed as tectorial membrane, and which is attaching to the inner aspect of the occipital bone. As you go still more deeper, remove all the ligaments here. A part of the posterior longitudinal ligament is evident here running behind the body of the vertebra. Then you find the plus-shaped ligament, which is the cruciate ligament, and it is going to have the transverse ligaments of the atlas and also the superior inferior longitudinal fascicles as well. Now, if you remove this part as well, you'll find that this is the dens of the axis to which the cruciate ligament was attaching, and attaching to that as well is the alar ligament. Alar means like the wings. It is located and is attaching the dens of the axis anteriorly to the occipital bone at the level of foramen magnum. And as we have removed the superior longitudinal fascicle of the cruciate ligament, more anterior to that will be apical ligament of the dens, which is attaching to the tip of the dens of axis there. So most anterior is the apical ligament of dens. Behind that is the cruciform ligament, having a superior longitudinal fascicle, inferior longitudinal fascicle, and the transverse fascicle as well. Now this is the side view or sagittal section of the head neck region, and you can talk about those membranes once again posterior to anterior. And as you can observe that this is the ligamentum flavum, which is coming superiorly, and as it comes superiorly, you'll find it has been modified into posterior atlanto-occipital membrane. And then you notice there is the posterior longitudinal ligament, which is running behind the body of the vertebra. And this posterior longitudinal ligament, as it enters the foramen magnum, will change the name. Let us zoom this area, and you will notice that it is continuing upward as the tectorial membrane then. So tectorial membrane is the continuation of the posterior longitudinal ligament as it enters the foramen magnum and attaches to occipital bone on the inner surface. And in front of the tectorial membrane, you can see the plus-shaped ligament, cruciate ligament. That cruciate ligament is having superior and inferior longitudinal fascicle and the transverse fascicles as well. So let us zoom the area of that ligament as well. As you will notice that in front of the tectorial membrane is the cruciate ligament, and there is a superior longitudinal fascicle, and there is the transverse portion of the cruciate ligament, and this is the inferior longitudinal bundle of the cruciate ligament. And more anteriorly is the apical ligament of the dens, which is attaching to the apex of the dens and the occipital bone. So here is the most anterior ligament in the sequence. As we said, there is posterior atlanto-occipital membrane. Then after that, we have the posterior longitudinal ligament becoming the tectorial membrane, and after that we have the cruciate ligament, and after that we have the apical ligament of the dens. And still more anterior, you will find that is the anterior atlanto-occipital membrane. And this anterior atlanto-occipital membrane is continuation of anterior atlanto-axial membrane, which it itself is a continuation of anterior longitudinal ligament, which runs in front of the vertebra body. So basically, we have anterior longitudinal ligament becoming anterior atlanto-axial ligament, becoming the anterior atlanto-occipital membrane, as the posterior longitudinal ligament becomes the tectorial membrane, and the posterior atlanto-occipital membrane is in the region of the ligamentum flavum, which itself is continuing as the posterior atlanto-axial membrane and the posterior atlanto-occipital membrane. As we look at the developing baby, the early fetal stage, we will find that length of the spinal cord is equal to the length of the vertebral column. And not only that, the spinal cord is attaching to the coccyx bone there. But later, the length of the vertebral column is becoming longer, and whereas the length of the spinal cord is going to be relatively shorter. So this happens because there is a disproportionate growth between the vertebral column and the spinal cord. But still you will notice that the spinal cord is attaching to the bone coccyx with the help of a fibrous attachment, and that attachment is called as the filum terminale. Attaching to the tip of the spinal cord, the original attachment is persisting. Now obviously that the spinal cord is not going to reach the end of the vertebral column at birth. Spinal cord termination is found at the upper border of the L3 vertebra, which within the age of 2 years after birth will reach the adult level. That is the transpyloric plane or the lower border of the L1 vertebra. Here you find the pylorus of the stomach as well and the termination of the adult spinal cord. Understand the pia mater which is covering the spinal cord not stop with the spinal cord. It continued downward and covered the filum terminale till to the bone coccyx. Filum terminale itself is made up of collagen fibers, which is now surrounded by the pia mater. And the pia mater covering the filum terminale, the collagen fibers will be attaching the bone coccyx down there. Now, pia mater reaches the bone coccyx, but not the arachnoid mater. You will notice that arachnoid sheath is terminating at the S2 vertebra lower border, and that is the termination of a space also under the arachnoid mater, which is called subarachnoid space, filled with the CSF. The subarachnoid space is stopping along with the arachnoid sheath at the S2 vertebra lower border. And we can do lumbar puncture here between the L4-5 vertebra. You are pushing a needle so that you can aspirate the CSF here. In the spinal cord, we see there are two enlargements. One is cervical enlargement, one is the thoracolumbar enlargement. The cervical enlargement is having some neuron bodies which will contribute to brachial plexus supplying the upper limb, and lumbosacral enlargement is having neuron bodies to supply lumbosacral nerves to the lower limb. The root value of cervical enlargement is 32, which is C3 and thoracic 2, and the lumbosacral enlargement is 13, which is the lumbar 1 and S3. The brachial plexus will have a root value between the C3 and T2, which is 5 root values, starting with number 5, which is C5, 6, 7, 8, and T1 from cervical enlargement. And sciatic nerve will have 5 root values, which are lying within this range and which are L4, 5 and S1 to 3. Supplying the lower limb. Now, this lumbosacral enlargement is protected by the last 4 thoracic vertebra, which is thoracic vertebra number 9, 10, 11, and 12, protecting the lumbosacral enlargement of spinal cord. Filum terminale has two parts. There is a longer pial part and a shorter dural part. The pial part is covered intimately by the pia mater and reaching the S2 vertebra lower border, which is also the termination of the subarachnoid space. So this pial part of the filum terminale is adherent to the pia mater closely. And below the S2 vertebral lower border, you will see there is a dural part of the filum terminale. In this region, the filum terminale, which is collagen fiber attaching to bone coccyx, was already covered by pia mater, is additionally covered by the dura mater. And that is a short length of the filum terminale. Ultimately, dura mater is going to fuse with the bone coccyx down there. To do the lumbar puncture, will put the patient in a flexion attitude and go feel for the highest point of the iliac crest and put a line here, which is called as the intercrestal plane also. It is at the level of the spine of the L4 vertebra, actually L4-5 interspace, and that is where you can push your needle to aspirate the CSF. You can also put the anesthesia agent for lumbar anesthesia. Now understand that the spinal nerves which are coming from the spinal cord in the cervical region, they go above the corresponding vertebra. Like, let me magnify this area. If it is the C1 spinal nerve, it is going above the C1 vertebra, which is the atlas vertebra. So accordingly, each spinal nerve keep passing above the corresponding cervical vertebra. But then we have 7 cervical vertebra and 8 spinal nerves. So the nerve which goes above the T1 vertebra is the C8 spinal nerve, which we will see in the magnified view of this diagram. But after that, since there is a mismatch between the number of spinal nerves and the vertebra being 7 and the nerve being 8, after that there is a transition of the spinal nerves. Now, each spinal nerve start passing below the corresponding vertebra. For example, now here, as I magnify the diagram, the T1 nerve is passing below the T1 vertebra. Now, after that, all the nerves are passing under their corresponding vertebra. Like here, you have the L1 spinal segment giving the L1 spinal nerve, and it is passing under the L1 vertebra, as observed here. So let us look at some diagrams which are for the lumbosacral region and cervical region as well. If you're talking about the cervical region, the rule is each spinal nerve is passing above the corresponding vertebra. So if this is the C6 nerve, then it is passing above the C6 vertebra. So C7 vertebra, the nerve is above that corresponding vertebra. But since the vertebra are only 7 and the nerves are total 8, Where is the C8 nerve passing? Actually, C8 nerve will be passing above the T1 vertebra. Then where is the T1 nerve passing? It is passing under the T1 vertebra. So this is the transition area. Prior to this, all the spinal nerves are passing above the corresponding vertebra. But below this level, each spinal nerve start passing under their corresponding vertebra. Like a T1 nerve is passing under the T1 vertebra. Let us continue in the lumbosacral region then. In the lumbosacral region, as you have witnessed earlier as well, the L3 nerve is passing under the L3 vertebra. And similarly, L4 nerve under the L4 vertebra, L5 under the L5, and S1 spinal nerve under the S1 vertebra. Now, as you can see, the cervical spinal nerves are short and straight course, whereas the lumbosacral nerves are long and more oblique. It happens because the spinal nerve has already stopped at the level of the L1 vertebra, and the nerves keep coming down to exit at their corresponding vertebral level. Also understand that slip discs are more common in the lumbosacral region. 90% of the patient will have problem in the lumbosacral slip disc, and 10% patient have cervical slip disc. The slip disc in the thorax region is very rare to find. In the level of cervical slip disc, you will see the nerve which is exiting at the intervertebral disc level is involved. Say, posterolateral herniation of the nucleus pulposus between C5, C6 vertebra, and the nerve exiting C6 will be involved. Similarly, if it is between C6, 7 vertebra, the nerve exiting C7 will be involved. And here it is C7, T1 vertebra, and C8 nerve will be involved. But this doesn't happen in the lumbosacral region. You will find that the nerve exiting at the same level is not involved, but the next nerve is involved. +1 nerve is involved. Say, for example, it is L3, L4, posterolateral herniation of nucleus pulposus. And it is not involving the nerve exiting at the level L3 because it is much more lateral, and the nerve which involved is the next nerve, which is L4. Similarly, if you have a posterolateral herniation of nucleus pulposus between L4, L5 vertebra, the L4 nerve exiting at the level is not involved, but the next nerve is involved, which is L5. Similarly here, the nerve involved is S1. And what if it is a midline herniation of the nucleus pulposus? If it is a midline herniation of nucleus pulposus, then all the nerves which are coming below that level will be involved. It will be a multiple nerve involvement. This is a single nerve involvement. Now, it is difficult to calculate the nerve values in the exam hall, so I'll give you a trick here to find a quick answer. The trick is very simple. If the examiner is telling that you have a slip disc between C5, C6 vertebra or between the L4, 5 vertebra, you just go to the upper vertebra, add +1, and that nerve is involved. Just go to the upper vertebra and add +1, and that nerve is involved. What does it mean? It means that slip disc between C5, C6 vertebra, the upper vertebra C5, C5 +1, C6 nerve is involved. Here, upper vertebra C6 +1, C7 nerve is involved. Here, upper vertebra C7 +1, C8 nerve is involved in the slip disc between the C7 and T1 vertebra. Similarly here, the trick is very simple. Go to the upper vertebra and add +1. Say, for example, slip disc between L3, L4, the L3 plus L1. L4 nerve is involved in the slip disc, and slip disc between L4, 5, the L4 +1, L5 nerve is involved, and slip disc between L5, S1, it is L5 +1, that is the next nerve, S1 nerve is involved, not the L5 which exit at the same level. Let me put this trick in a simple table now. It is very simple to remember. Upper vertebra +1 nerve is involved, C4 +1, C5 nerve is involved. So C5 +1, C6 nerve is involved. Upper vertebra +1 nerve is involved. Upper vertebra +1 nerve is involved. Upper vertebra +1 nerve is involved. +1 means the next nerve is involved. L5 +1 is L6, but there is no L6 nerve, so it is the next nerve, which is S1 nerve involved. It's a simple trick. To reach your answer, the nerve of compression. So, for example, this patient came to us and was telling, I have a burning sensation in the middle finger. The middle 3 fingers are C7 dermatome. So, we are testing C7 myotome, which is twice as reflex. It was weak. Now, if the C7 root value is involved, then the slip disc must be between C6 and C7 vertebra. Upper vertebra +1 root value is involved. So, that means the upper vertebra is C6 vertebra. So you focus your MRI between C6 and C7 vertebra. And you will notice the lesion is between C6 and C7. The root value is C7 involved, the dermatome or middle finger, and the myotome involved is the triceps reflex, and the triceps reflex is weak with the C7 myotome. This patient came with the problem of the little toe and lateral margin of the foot, and we said S1 dermatome is involved. Then we are checking the S1 myotome. By doing the ankle reflex, you are hitting the tendon of the Achilles, and you want the ankle joint to undergo plantar flexion, which is not happening. Ankle jerk is weak. So the nerve involved is S1. The slip disc must be between the higher vertebra, and that is L5 S1 vertebra. You are focusing upon that region by MRI, and you found that there's a slip disc between L5 S1. There's a upper vertebra plus one nerve is involved, and there is a sensory disturbance in the little toe S1 dermatome, and a problem of gastrocnemius plantaris soleus muscle, which is involved in plantar flexion at the ankle joint, and ankle jerk is reduced or lost. Here we are looking at the various levels of the spine of the vertebra. Say, for example, C7 vertebra is called the vertebra prominence, as the spine is quite prominent. And then we see the T3 vertebral spine process, which is at the level of the scapular spine. That is the point where the beginning of the oblique fissure of the lungs is observed. It will go like this, obliquely on either side. And then we have the T7 spine of the thoracic vertebra, and that is where you have inferior angle of the scapula. This is the T12 thoracic spine. Attaching there is the 12th rib. And we can talk about the renal angle here. That is between the lower border of the 12th rib and the erector spinae muscle, especially sacrospinalis part of the erector spinae medially, and the 12th rib laterally. That is the renal angle below the 12th rib, and renal colic begins here. T12 dermatome below the 12th rib. Root value of the kidney. At the L4 spine, lumbar 4 spine vertebra, you have the intercrestal plane, highest point of the iliac crest, and that is where you can do lumbar puncture between the L4, L5 vertebra. And then you have the S2 vertebral spinous process, which is at the level of posterior superior iliac spine on the hip bone. Here we are looking at the two triangles at the back region. There is upper and lower. The upper is a triangle of auscultation having very few muscles at the floor, and you can take your stethoscope and put here for auscultating the inner viscera. And it is bounded by the medial border of the scapula. You also find that it is having a boundary of the trapezius muscle there, and the boundary of the latissimus dorsi muscle here. Muscle of lower back is latissimus dorsi, muscle of upper back is the trapezius. So, laterally is the scapula, and superiorly is the trapezius, inferiorly is the latissimus dorsi. Then we can also talk about the lumbar triangle of Pettit, which is bounded by the ilium part of the hip bone inferiorly, relates to the latissimus dorsi muscle as well. Then what is the muscle anteriorly? The muscle of anterior abdominal wall, which is called as the external oblique muscle. So that is the lumbar triangle, Pettit's triangle. As we talk about the type of ribs, we will find that there are some ribs which come from posterior vertebra and anteriorly to the sternum bone, called as vertebro-sternal ribs. They are also called as true ribs, as you can see here. The true ribs are rib number 1 to 7 because they are all connected to the vertebra posteriorly and sternum anteriorly. So these are the 7 true ribs. When it comes to the next, they are called as the false ribs. That is the last 5 ribs. So here are the false ribs, which is rib number 8 to 12, and out of which the last 2 are also called as floating ribs because they have no anterior attachment. Then what about the rib number 8, 9, 10? They do have one anterior attachment, as you can see, to the costal margin. So as you can see, rib number 8, 9 and 10, they are attaching to costal cartilage and making a costal margin, and attaching to costal cartilage of rib number 7, indirectly attaching to sternum. So false ribs are called so because they are not attaching to sternum bone directly. And the rib number 8 to 10 are also called as vertebrochondral ribs because they come from the vertebra and attaching to chondro, the cartilage. Whereas the rib number 11, 12, as you can see, they are called floating ribs, and they are vertebral ribs because they do not attach to the sternum at all. So here also you can see the rib number 8, 9, 10 are the vertebrochondral ribs, and they are indirectly attaching to the sternum via the costal margin. The costal cartilage of 7th rib will help them to attach to the sternum. They are false ribs as such. Now here is the repeat information. The first 7 ribs are the true ribs and they are attaching to the sternum. So vertebrosternal ribs, vertebrosternal ribs, whereas the false ribs are the rib number 8 to 10. As you see, vertebrochondral ribs. And these vertebrochondral ribs are attaching to the costal margin and indirectly to the sternum via the costal cartilage of rib number 7. And then you have the floating ribs, rib number 11, 12. Their anterior end has no attachment as such. And here are the rib number 11 and the rib number 12. Their anterior ends are free with no attachments at all. Looking from the front view, you will see that there are rib number 3 to 9, which are typical ribs having the features as a typical rib should have. But rib number 1, 2 or the rib number 10, 11, 12 are atypical ribs because they do not have the features as a rib is expected to have. Now all these ribs 1 to 10 you will find they are coming to attach to sternum maybe directly or indirectly, and except the rib number 1 here and the rib number 10 there, all the ribs except 1 and 10 have synovial joints. So may it be rib number 2 or 3, 4, 5, 6, 7 or rib number 8 or 9, they are all synovial joints. Synovial joints are required for the free movements and breathing movements, except 1 and 10. 10th rib has a fibrous joint here, is not synovial. And first rib is having a synchondrosis primary cartilage joint and it is not synovial. As we look at the midline joint, like this is the manubriosternal joint, it is a symphysis. But as you talk about the xiphisternal joint, though some books will write it as a symphysis, you better answer it as synchondrosis, primary cartilage joint. If synchondrosis is not an option, then you may take your next answer as symphysis. So it is basically a synchondrosis, but some books may write it as a symphysis as well. Here we are looking at the fetal veins, which are cardinal and the vitelline and the umbilical veins, and want to see what is their future derivatives. There are cardinal veins which drain the body wall, there are vitelline veins which drain the yolk sac, and there are the umbilical veins which drain the placenta. Umbilical veins as such have no future in the adult. As you remove the placenta, they get degenerated and there will be some vestigial remnants in the adult. The vitelline veins which drain the yolk sac are going to contribute to the portal venous circulation, as the yolk sac is contributing to the gut tube involved in absorption of the nutrients that will be carried by the portal vein towards the liver for metabolism and further towards the heart. The metabolites are carried by the portal venous circulation. Vitelline vein is contributing. And what about the body wall? There's a boundary line diaphragm, body of the diaphragm drain into superior vena cava, body below the diaphragm drain to inferior vena cava. We have got one anterior cardinal vein which later contribute to superior vena cava and drain the venous blood of body above diaphragm. And then we have the posterior cardinal vein which is draining the venous blood of the body below diaphragm. All these veins may be the cardinal or the vitelline or umbilical veins. They drain into venous end of the heart tube, which is sinus venosus. And the sinus venosus pushes the blood into the arterial end, which is truncus arteriosus. And the truncus arteriosus will push the blood into the aorta, which are 2 dorsal aorta. We also see that some pharyngeal arches are developing in the head neck region, and they are going to give us arteries like carotid artery and arch of aorta and subclavian artery and pulmonary arteries, which keep connecting the aorta with the aortic sac, which is connected to the heart tube. So we have got the arterial end of the heart tube, and then we have the aortic sac which push the blood into aortic arches which push the blood into the dorsal aorta, one on each side of the midline. Inferiorly, it is fused to become one dorsal aorta, supplying the body with the intersegmental arteries and also the vitelline artery to the yolk sac and the umbilical arteries to the placenta. Now let us look at the front view of the heart and the sinus venosus receiving 3 set of veins from each side, right side, left side. Actually, there will be a right horn and left horn of sinus venosus receiving these veins. So here is the right horn and the left horn of the sinus venosus, and receiving 3 set of veins from either side, right and left side of the body. What we notice is there are anterior cardinal veins on each side, and they are draining the body of the diaphragm, especially the head neck region, whereas the body below diaphragm is drained by posterior cardinal veins and contributing to the lower veins, especially the iliac veins in the pelvic region. Together they join to form the common cardinal vein on right side as well as left side, opening into right horn, left horn of the sinus venosus and push the blood into the heart tube. The anterior cardinal vein will be contributing to the superior vena cava and posterior cardinal vein will be contributing to the inferior vena cava. But remember, the right veins are contributing to the SVC IVC, not the left, because the left veins are regressing. If we have persisting anticardinal vein, you may have double SVC, and if you're persisting postcardinal vein, we have double IVC. We want these to disappear or regress as such, so that the SVC, IVC are present only on the right side of the midline. We can also see the umbilical veins coming from placenta, the right and the left umbilical veins, and in the fetal circulation, right regresses and left is left. So only left umbilical vein is left, which will be degenerated in the adult and form ligamentum teres of lever, having no function at all. They also drain the placenta towards the right horn, left horn of the sinus venosus, towards the heart tube. And then we have got the right and left vitelline veins. These right and left vitelline veins are actually passing through septum transversum, a structure developing in the mesenchyme, later contributing to the central tendon of our diaphragm and some of the connective tissue of the lever, through which the vitelline veins are passing towards the right horn, left horn of the sinus venosus and push the blood towards the heart tube. The septum transversum is going to break the vitelline vein into some channels called as the right hepatocardiac channel and the left hepatocardiac channel. It is the right hepatocardiac channel which will be helping us to form the terminal portion of the inferior vena cava, which carries the blood of the liver towards the heart. So basically, it is the right vitelline vein which contribute to terminal part of IVC, as it becomes the right hepatocardiac channel within the septum transversum. The right vitelline vein is also important to form the portal vein, along with minor contribution from the left vitelline vein and anastomosis between the two. Vitelline vein drain the yolk sac. Yolk sac will later become gut tube, like this, the duodenum, shown here. Let us magnify this area to see how the portal vein is formed. Then we can also move on to discussion of the formation of the inferior vena cava. But first is the portal vein formation. As we understand, this is the yolk sac which has now formed the gut tube and duodenum part of the gut tube. Running on either side, right and left vitelline veins are there. So here is the right-sided vitelline vein, which is the major contributor to portal vein, and that is the left vitelline vein, which usually regresses most of it. There is an anastomosis between the two, which is on the dorsal side and contributing to the portal vein formation. Portal vein basically come from a small contribution of the left vitelline vein and this anastomosis between the two, and major contributor is the right vitelline vein, as you can see it here. So, minor contribution from the left vitelline vein and some contribution in the anastomosis between the two, but the major contributor is the right-sided vitelline vein forming the portal vein. The portal vein is passing behind the first part of the duodenum and divides right and left branch inside the liver at porta hepatis. In the fetal circulation, it is a requirement that the left vitelline vein is connected to the inferior vena cava directly by a ductus venosus to bypass the liver, because the oxygen carried by the left umbilical vein need not be going into the liver, as the liver is immature in a baby. So most of it will bypass the liver, passing through the ductus venosus and entering directly into the inferior vena cava towards the heart. Now here is the table which will tell us about the various derivative of the three embryonic veins. The vitelline veins basically for portal venous circulation, absorption of the nutrients from the gut tube and carried to the liver for metabolism, and further the metabolites should be carried towards the heart, all contributed by the vitelline vein. Whereas the umbilical veins, they degenerate, and it is the left umbilical vein which will form ligamentum teres later. Coming to the cardinal veins, we have to remember a few of them. As you will notice, the anterior cardinal vein is contributing to upper veins of the body, especially superior vena cava and the neck veins like interjugular vein. And the posterior cardinal vein is contributing to the lower body, venous drainage especially, portion of IVC and the common iliac veins in the pelvis region. We also have got subcardinal veins, and they contribute to some part of the IVC, which is renals and suprarenal. Along with the renal and granule veins, for which it is contributing. And then we have got the supracardial veins, which are basically to drain the thorax region, forming azygous venous system, but also contribute to the infrarenal portion of the inferior vena cava. To discuss the inferior vena cava, we got a diagram now talking about the four veins, which are the supracardinal, subcardinal, and the posterior cardinal, plus the right-sided vitelline vein, because it is the right-sided vitelline vein which form a terminal portion of inferior vena cava. Remember, the portal vein is basically contributed by the right-sided vitelline vein, though it has a minor contribution from the left and the dorsal anastomosis between the two, but majorly it is the right-sided vitelline vein contributing to the portal vein. Now, as we talk about the inferior vena cava, it has four major contributing veins. The right-sided vitelline vein is contributing to hepatocardiac channel and the terminal portion of IVC, which enters the heart, right atrium. The subcardinal veins are contributing to the renal and suprarenal IVC, and the infrarenal IVC contributed by the subcardinal veins. And then it is the initial portion of the IVC is contributed by the posterior cardinal vein. Now remember that all these veins are right-sided because the inferior vena cava is right-sided. The left-sided veins regress. If we have persisting left veins, then we'll have double IVC. Let us look at for the details of the formation of IVC then. Here again we show the anterior cardinal vein, posterior cardinal vein, and the common cardinal vein. Anterior cardinal vein, posterior cardinal vein together joining to form the common cardinal vein on either side. Now our focus will remain on the right-sided posterior cardinal vein, which will form the initial portion of the inferior vena cava. Here we should also talk about the supracardinal veins developing here. They basically drain the thorax region by giving some azygous venous system, but they also contribute to the infrarenal portion of IVC. And then we have got the subcardinal vein. The subcardinal veins are contributing to the renal and suprarenal portion of IVC. They also form the renal and the gonadal veins. And here we have got the right-sided hepatocardiac channel, which was formed by right-sided vitelline vein, as it is passing through septum transversum and was broken into the right hepatocardiac channel, contributing to terminal portion of IVC, which enters right atrium of the heart. Now let us look at the formation of IVC here, which is contributed by, in the beginning, right-sided posterior cardinal vein, the initial portion of IVC. Then we have the infrarenal portion of the IVC below the kidneys, contributed by supracardinal vein. And then we have the renal, suprarenal portion of the IVC, which is contributed by subcardinal vein. And then we have the right-sided hepatocardiac channel, contributed by right-sided vitelline vein, forming the terminal portion of IVC. You can represent that here as well now. So the first contributor is the posterior cardinal vein on the right side, and then we have got supracardinal vein on the right side. Later there is an anastomosis with the subcardinal veins, forming the renal, suprarenal portion of the IVC. And then we have got the anastomosis between the right hepatocardiac channel or the right vitelline vein, forming the terminal portion of IVC, which enters the right atrium ultimately. So in conclusion, it is the right-sided posterior cardinal vein, and then we have the supracardinal vein, then we have the subcardinal vein, and then we have the right vitelline vein, contributing to the inferior vena cava. Sometimes we have double IVC, maybe there was a persistent supracardinal vein on the left side, and that is the infrarenal portion of IVC persisting, and a double inferior vena cava is observed. Normally it should regress. Here we are looking at the heart tube having the 5 parts and later contributing to the 4 chambers of the heart as such. In the beginning, there are 2 heart tubes which are fused in the midline to form the one heart tube, which has a lower venous end, the upper arterial end. The lower venous end is called sinus venosus, and upper arterial end is called truncus arteriosus. There is a right horn, left horn of sinus venosus, so bringing the blood from the 3 fetal veins, that is the cardinal, umbilical, and vitelline veins, pushing blood into the sinus venosus, which will then push the blood into primitive atrium, primitive ventricle, and the bulbus cordis, which further pushes it towards the truncus arteriosus. The sinus venosus is the smooth inflow tract. That is the rough part of the 4 chambers of the heart will be formed by the primitive atrium and primitive ventricle. The rough portion is trabeculator portion. The smooth outflow tract is bulbus cordis, which will form the smooth part of the ventricles, and the truncus arteriosus will form the pulmonary trunk and the ascending aorta. After sometimes there is a cardiac looping, and what happens is the atria, they are going more superior and the ventricles, they come inferior. Also, the upper arteries will come anterior, anterior, and the lower veins will go posterior, posterior. And we find that there are some septa formation, like this is the interventricular septum dividing primitive atrium into two chambers, right ventricle, left ventricle, and there will be interatrial septum dividing the primitive atrium into right atrium, left atrium. Now let us have a good look over the formation of the septa and the chambers of the heart. As I'm telling, there is a lower venous end receiving the blood and the upper arterial end which is sending the blood out of the heart. The cardiac looping brings the upper arterial end anterior, and then you will see the lower venous end is going posterior, and you will see that between the anterior arteries and posterior veins there is a space which is going to form transverse pericardial sinus. We can put our finger inside transverse pericardial sinus to put the arteries anteriorly. The veins will remain posteriorly. In fact, the upper arterial end will form the two arteries called ascending aorta and the pulmonary trunk. This is actually the truncus arteriosus, and the posterior venous end is forming the superior vena cava, inferior vena cava. Here once again we look at the 5 parts of the heart tube, and I find that the lower venous end is going posterior. As you see, it is going posterior, and then it will be forming some of the venous part of the heart and receiving end of the heart, whereas the upper arterial end, which is the truncus arteriosus, keep coming anterior, and when it reaches anterior will form the two arteries, that is the ascending aorta and the pulmonary trunk. And we can put our finger inside the transverse pericardial sinus which is developing between the anterior arteries and posterior veins. The anterior arteries will be the pulmonary trunk and the ascending aorta contributed by the truncus arteriosus, and posterior veins will be the superior vena cava, inferior vena cava, draining into the lower venous end, that is the sinus venosus, which later would have formed the smooth part of the atria. As I suggested, atria goes superior and posterior, and ventricles come inferior and more anterior. This happens because there is a cardiac looping going on. Let us look at the transverse pericardial sinus now. So here we are putting our finger in the transverse pericardial sinus and trying to pull the two vessels anterior. The vessels are pulmonary trunk coming from the truncus arteriosus and the ascending aorta as well. During heart-lung machine operations, you have to pull these two vessels anterior and put a ligature around them, pipe inserting some cannula inside, and behind your finger will be some venous vessels. Like here you can see your finger is in the transverse pericardial sinus, and behind that is superior vena cava, behind your finger, or behind the transverse pericardial sinus. Now we once again look at the lower venous end of the heart, which is right horn, left horn of the sinus venosus, and which is going posterior to the heart. We want to look at the posterior view of the heart in a developing scenario to see what is the future derivative of the right horn, left horn of the sinus venosus. So here is the posterior view of the developing heart, showing the right horn of the sinus venosus and the left horn of sinus venosus. The left horn of sinus venosus will become very small, contribute to the coronary sinus of the heart and receive venous blood of the heart, whereas the right horn is absorbed into the posterior wall of primitive atrium to contribute to the sinus venerum, which is the smooth posterior wall of the right atrium, whereas the rough anterior wall being contributed by primitive atrium. You can also observe that the anterior cardinal vein, posterior cardinal vein, forming the common cardinal vein on either side, will be contributing to the superior inferior vena cava, but the left-sided veins are regressing, that only the right-sided veins are contributing. So we have anterior cardinal vein contributed to superior vena cava and posterior cardinal vein contributed to inferior vena cava there. They open into right horn of sinus venosus and the left horn of sinus venosus. Now let us look at the next stage of the diagram. As you can make out, the right horn of the sinus venosus is getting absorbed into posterior wall of primitive atrium to form the sinus venerum, which is the posterior smooth wall of right atrium. And the left horn of sinus venosus is getting smaller and forming the coronary sinus of the heart. That coronary sinus of the heart receives the venous blood of the heart and drain into the right atrium from the posterior wall. Let us magnify this diagram now. So here is the coronary sinus of the heart, which is the left horn of sinus venosus, future derivative, and opens into the right atrium posteriorly. Along with that, there is opening of superior and inferior vena cava as well. So there are 3 openings into the right atrium from the posterior wall, which is the sinus venerum part of the right atrium. And that sinus venerum came from the right horn of sinus venosus getting absorbed into the primitive atrium. The primitive atrium will form the right atrium, which is anterior wall, and there is a boundary line between the rough anterior wall and smooth posterior wall. known as the sulcus terminalis from the outside and crista terminalis from the inside. You also notice there are 4 pulmonary veins opening into the posterior wall of the left atrium, and they are derived from the left atrial wall. Now I want to look at the front view of the right atrium. We'll open the right atrium, anterior wall goes there, and we'll look at the posterior wall of the right atrium in the next diagram. So this is the anterior wall which we have opened like this. This is the rough trabeculated portion having some pectinate muscles also coming from the primitive atrium lying anteriorly. Whereas the right horn of the sinus venosus will absorb posteriorly to form the sinus venerum or smooth posterior wall of right atrium, the yellow color, receiving 3 openings from posterior wall. The superior vena cava contributed by the anterior cardinal vein, and inferior vena cava contributed by posterior cardinal vein, and coronary sinus contributed by the left horn of the sinus venosus, whereas the right horn of sinus venosus is forming sinus venerum, the posterior smooth part of right atrium. And at the upper end of the crista terminalis develops the SA node, which lies in the subepicardial region. Some books say it is in the myocardium. Crista terminalis is seen on the interior of the right atrium. Outside it is called sulcus terminalis. It is the boundary line between the anterior wall of right atrium and smooth posterior wall of right atrium. Here you can also see the interatrial septa. The first septum comes on the left side, and it is called as septum primum. The second septum comes on the right side and is called as the septum secundum. There's an opening in the septum secundum called as the oval foramen, which will let the blood come from the right atrium towards the left atrium in the fetal circulation. And the blood will reach the left atrium passing through a foramen which is in the septum primum and slightly higher location. And that is called foramen secundum. Let us look at the formation of interatrial septum now. As we know, in the beginning, there is a single primitive atrium and single primitive ventricle. The atria goes superior and the ventricle come inferior during the cardiac looping. And between the lower ventricle, upper atria, there is AV cushions, which later form the mitral valve and the tricuspid valve components. Now there comes the first septum or septum primum from the roof of the primitive atrium and going to fuse with the atrioventricular cushion here to divide the primitive atrium into 2 chambers, right atrium and the left atrium. Now it is a requirement in the fetal circulation that blood of the right atrium must go to left atrium, bypassing the lung, and it is doing so. But as the septum primum is coming down and fusing with AV cushion, there is a narrowing of the channel where the blood was passing from right atrium to left atrium. Now it has to pass through an opening which is called the first foramen or foramen primum. Later, as the septa get fused with the AV cushion, it is understood that the foramen primum is closed. Then how do we send blood of the right atrium to left atrium? There is a second foramen formation which is foramen secundum in the same septum primum. So maybe it is foramen primum or the foramen secundum. Both of them come in the same septum, which is the septum primum, and the blood continue flowing from the right atrium to the left atrium as such, but this time from using the foramen secundum. Now as the blood is passing through right atrium to left atrium through the foramen secundum and the foramen primum is disappeared, a next septum comes, which is second septum or septum secundum and coming on the right side of the first. The septum secundum will have an opening inferiorly, and that opening is called as foramen ovale. We can keep sending blood through the foramen ovale from the right atrium towards the left atrium. So how the blood is passing now? First the blood is in the right atrium, then foramen ovale, then goes obliquely upwards and passes through the foramen secundum and then comes to the left atrium. The flow is oblique because the foramen ovale is inferior and the foramen secundum is superior. Later, when the baby is born, there is a first breath taken, a lot of blood goes into the lungs, and we will find left atrial pressure is high. As the left atrial pressure is high, it will push the 2 septa close. The foramen secundum is opposing on the septum secundum and get obliterated, and foramen ovale is opposed to the septum primum on the left side and get obliterated. Let us look at that in the next diagram as well. We will find that foramen ovale would have been replaced by fossa ovalis, having a rim margin, thickened margin, which is called limbus fossa ovalis. Understand? Limbus fossa ovalis will be in the septum secundum, which is on the right side, whereas the floor of the fossa ovalis will be a septum on the left side, which is the septum primum. So here we have the right atrium, left atrium, and blood cannot pass from here to there, as the septum primum has been opposed to the septum secundum on the right side. You see there's an opening in the septum secundum inferiorly, and that is called foramen ovale in the fetal circulation. Now it has become fossa ovalis, whereas that is the location of the foramen secundum. Foramen secundum was a bit higher and lying in the left septum, which is septum primum. This is the septum primum lying on the left side. And what you see at the floor of the fossa ovalis is the septum primum. and the thickening which appears at the margin of the fossa ovalis, which is called limbus fossa ovalis, is actually on the right side and on the septum secundum. You can observe the same thing here as well. This is the fossa ovalis, and the floor is the left septum or the septum primum. Whereas the limbus fossa ovalis, which we see here, is on the right side and it is on the right septum, which is septum secundum. In this diagram, we have opened the right atrium and we are seeing at the Koch triangle, which is the location of the AV node, atrioventricular node, at the lower part of the interatrial septum. The AV node lies at the apex of the Koch triangle, which itself has the three boundaries. One is opening of the coronary sinus, which is from the posterior wall of the right atrium, and the other is septal cusp of the tricuspid valve. Tricuspid valve is the right atrioventricular valve which is guarding the flow of right atrium towards the right ventricle, preventing the backflow into right atrium. It has the three cusp, and we are looking at the septal cusp of the tricuspid valve, forming the boundary of Koch triangle. And then we have a tendon of Todaro. This tendon of Todaro is subendocardial collection of some collagen fibers. Radiologically, it is evident, and we mark the Koch triangle to mark the AV node. Say, for example, we have a case of AV nodal reentry tachycardia. In that case, we will do radiofrequency ablation of the Koch triangle and destruct the AV node. No more AV node, no more AV node induced tachycardia. Here we are looking at the formation of the AP septum, the aorta pulmonary septum, which is derived from the neural crest cells. The neural crest cells migrate towards the truncus arteriosus and form some ridges which are called truncal bulbar ridges. Some books will say conotruncal ridges in the region of truncus arteriosus, and forming a septum which is called AP septum, which is a spiral septum, and dividing the truncus arteriosus into two vessels. The anterior vessel pulmonary trunk and posterior vessel is the ascending aorta, and lying between the two is the AP septum, the aorta pulmonary septum, which is a spiral septum normally. Now what happens if we do not get the neural crest cell here? Then we will not have the truncal bulbar ridges, and we will not have the AP septum, and the old vessel will be persisting, which is persisting truncus arteriosus. Anomaly number 1. Anomaly number 2, it might happen that the AP septum is not a spiral septum, it is a straight septum. In that case, the two vessels are going straight, transposition of great vessels. And the third anomaly, which is tetralogy of Fallot, what happens is the AP septum has migrated anteriorly. So the anterior vessel become narrow, suffering from pulmonic stenosis, and the posterior vessel become large, which is overriding aorta. Tetralogy of Fallot. Let us look at all the three now, but first you look at the normal heart. Normally, AP septum is a spiral septum, so vessels are also spiraling. The pulmonary trunk is anterior and the ascending aorta is posterior. So here is the right atrium, which is pushing the deoxygenated blood towards the lung via the pulmonary trunk, which is lying anteriorly. Now this blood will go to the lungs by pulmonary arteries and oxygenated, come back to the left atrium, to the left ventricle. It's a case of persisting truncus arteriosus because AP septum is absent, and we do not have the two vessels like we should normally have. The right ventricle sending the blood into pulmonary trunk, or the left ventricle sending the ascending aorta is missing. So we do not have ascending aorta or pulmonary trunk. In fact, there is a primitive vessel which is called as the truncus arteriosus still persisting. In that case, there is a mixing of blood because both the ventricles sending blood into the same vessel, and there will be cyanosis in the baby. The next case is transposition of great vessels. When AP septum is not spiral, the vessels are not spiral, they are straight. And as you understand, the venous blood of lower body come into inferior vena cava and the right atrium. So does the superior vena cava. Venous blood body above the diaphragm. This deoxygenated blood comes to right ventricle and needs to go to the lungs for oxygenation, but what we see here is the deoxygenated blood is entering the ascending aorta and going back to the body without oxygenation. This way the survival is not possible. If you want this baby to survive, then you must have some communication like PDA. Patent ductus arteriosus can still send back some of the deoxygenated blood into the lungs for oxygenation. In this case, you see the pulmonary trunk is opening into the left ventricle and ascending aorta opening into the right ventricle. The vessels are going straight. They are not transposed, which normally they should be if the AP septum was spiral. And if the AP septum is not spiral, then they are straight and open into different chambers. If you want such a baby to survive, then you should have some communications like ASD and VSD and PDA, sending more and more blood towards the lung for oxygenation, and the baby might survive, but the baby will definitely have cyanosis. Now, this is the case of tetralogy fillet, which is anterior migration of AP septum. And as the AP septum has migrated anterior, the anterior vessel became narrow, suffering from pulmonic stenosis. Now, since there's pulmonic stenosis, there is a lot of pressure exerted on the right ventricle, which undergoes right ventricular hypertrophy, trying to push the blood into narrow chamber. But if it cannot, then it will start to push the blood into the other vessel, which is opening here at the junction. It is called as the overriding aorta. It is understood that if the anterior vessel was narrow, then the posterior vessel became large, overriding aorta. It was overriding the interventricular septum, opening into both the ventricles. Not only the left ventricle pushing blood into the aorta, but the right ventricle is also pushing the blood into aorta, and which is a high pressure vessel. So this right ventricle undergoes still more hypertrophy because trying to push the blood into high pressure zone of aorta. And because there is the overriding aorta, there is a ventricular septal defect. Mixing of blood between the ventricles will be seen. So there are four things basically. Number one, it is pulmonic stenosis. Number two, it is overriding aorta. Number three, there is a mixing of blood, ventricular septal defect. And number four, resulting right ventricular hypertrophy. And if there is also atrial septal defect, then it becomes pentology of fillet. And mixing of blood will be between the atria as well. These are all the three AP septum anomalies, maybe persisting truncus arteriosus, transposition of great vessel, or tetralogy of fillet. They present with the cyanosis. They are cyanotic heart diseases. Here we are looking at the fetal circulation, and as we understand, inside the umbilical cord we have two umbilical arteries and two umbilical veins, but later the right umbilical vein regresses and left umbilical vein is left. So as you can see, we are showing the left umbilical vein, which is red color blood because it is oxygenated blood from the mother coming to the placenta and towards the liver. It is moving. Whereas the umbilical arteries we are showing in blue color because they carry deoxygenated blood from the baby towards the placenta and mother so that it can be oxygenated further by maternal side. So here we have two of them seen in the umbilical cord. Now, as the oxygenated blood coming from mother passing through placenta and left umbilical vein is going to reach the liver. Liver is immature in the fetus, so we would not like to give much of blood to the liver. We have to bypass the liver, and for that purpose we have a shunt which is called ductus venosus. So here is the blood coming, and as you can see, this blood is going to bypass the liver, and that communication is called as the ductus venosus, and using the ductus venosus, the blood is going to enter directly into inferior vena cava, and the inferior vena cava will take it to the right atrium. Now this blood which comes to right atrium has to bypass the lungs because the lungs are immature in a baby and you don't want to send much blood into the lung. To bypass the lung, it will be using the foramen ovale and come to the left atrium. So that is the foramen ovale which is sending blood from right atrium to the left atrium. And this blood will then enter the left ventricle and the aorta and the carotid arteries to supply the brain. Most of the oxygenated blood should reach the developing brain by passing the lungs as well as the liver in fetal circulation. So here we see that the left atrium has sent the blood into the left ventricle, which is pushing the blood into the aorta, and aorta is pushing the blood towards the carotid artery and towards the brain. High oxygenation concentration of blood is reaching the brain. Then what about some of the blood which is entering the right atrium and the right ventricle and then going towards the pulmonary trunk? That blood can be bypassing the lung using what is called as ductus arteriosus there. So here we show that some blood which is coming from the right atrium into the right ventricle is passing through the pulmonary trunk but bypassing the lungs using ductus arteriosus, and thus most of the blood do not reach the lung. Now the deoxygenated blood is collected by the aorta into the iliac arteries, and iliac arteries will be pushing that deoxygenated blood into the umbilical arteries. So here we have got the aorta, which is collecting the deoxygenated blood, and that is sending into iliac arteries here in the pelvis region, and the iliac arteries will be sending further it into the umbilical arteries, which are going to send this blood towards the placenta and the mother for oxygenation. Now, after birth, the left umbilical vein is obliterated and it is going to become ligamentum teres of the lever. And when you are talking about the ductus venosus, it will be obliterated to become ligamentum venosum. And when you are talking about the foramen ovale, it will be becoming fossa ovalis. And when it comes to the ductus arteriosus, it will be physiologically obliterated within day 1 to 4 of the birth of the baby by vasospasm, thus stopping the blood passing through the ductus arteriosus. And within the 3 months of the birth, that is about 12 weeks, the anatomical closure will occur, and there will be tunica intima proliferation, fibrosis, and then anatomical closure by the 3rd month or 12th week maximum. And then we'll find that it has an adult remnant, which is called as ligamentum arteriosum. Thus, the physiological closure should occur maximum of the 4 days or 96 hours after birth due to vasospasm, and the anatomical closure should occur within 3 months, which is 12 weeks, and that is due to tunica intima proliferation. And the remnant is ligamentum arteriosum there. And what happens to the umbilical arteries? They will be obliterated to form the medial umbilical ligaments. And these medial umbilical ligaments will be seen running in the anterior abdominal wall, for which we have a separate diagram. Understand that the proximal part of the umbilical arteries will be persisting in the adult, and they are called as the superior vesical arteries, supplying urinary bladder even in the adult, whereas the distal part of the umbilical arteries are obliterated. So we have one superior vesical artery on each side, and it is the proximal unobliterated part of the umbilical arteries persisting still in the adults, supplying urinary bladder. Now, as we were talking about the anterior abdominal wall, lower abdominal wall, which is below the umbilicus, you will see some fold which is produced by the umbilical arteries, remnant. They are called as the medial umbilical ligaments, one on each side, and covered by some peritoneal fold, which will be called medial umbilical fold. So basically, we have the two umbilical arteries which have been obliterated to form medial umbilical ligaments, but covered by some peritoneal fold, and which is called medial umbilical fold towards the umbilicus in the lower abdominal wall, anterior side. Whereas the left umbilical vein was going towards the lever, and it will be carried by a double fold of peritoneum, which is called falciform ligaments, towards the lever. And later, this falciform ligament is carrying a remnant of the left umbilical vein, which is called ligamentum teres of the lever. Now, what is this median umbilical ligament for? You can notice that this is median umbilical ligament attaching to the apex of the urinary bladder here. In the fetal life, it was called as the allantois, and later it becomes urachus in the adult. And that urachus is going to form a ligament in the midline, which is called median umbilical ligament. And that allantois, which is now urachus, which is now median umbilical ligament, is covered by a peritoneal fold, which is called median umbilical fold, which you can see here. So in the fetus, it is allantois. In the adult, it is urachus, which is also called as the median umbilical ligament. And that median umbilical ligament is covered by some peritoneum, and that is called median umbilical fold. Now you have got one median umbilical fold and the two medial umbilical fold, which were covering the obliterated umbilical arteries. What is this lateral umbilical fold for? As you can see, there are two lateral umbilical folds also. They cover some blood vessels which are called as the inferior epigastric vessels. And those inferior epigastric vessels are going to enter the rectus sheath. Before they enter the rectus sheath, they are covered by a fold of peritoneum, and that is called as the lateral umbilical fold. So they are carrying the inferior epigastric vessels there. In the present diagram, we are talking about the four borders of the heart, and as you can see, this is the front view of the thoracic skeleton. This is the manubrium bone, this is the sternum, this is the manubriosternal junction. And at the manubriosternal junction, you have the costal cartilage number 2 coming from either side. Now, at the lower border of the costal cartilage number 2 on the left side, you put 1 point. And put one more point at the upper border of the costal cartilage number 3 on the left side. And as we join the 2 points, it will be the upper border of the heart. Now, as we are talking about the right border, you have to put a line which is convex towards the right side, and it is joining the second point with the third point, which is on the costal cartilage number 6 on the right side. So as you join the point number 2 and 3, and that is the right border of the heart. And then we have to take a fourth point, which is actually about 9.5 centimeter from the mid-sternal line and in the fifth intercostal space. And then join it with the fourth point here. So as you connect the third point with the fourth point, that will be the lower inferior border of the heart. And when you are talking about the left border, you have to connect the fourth point with the first point there. That would be the left border of the heart. So there are 4 points basically. It is the lower border of the costal cartilage number 2 on the left side. It is the upper border of the costal cartilage number 3 on the right side. It is the sixth costal cartilage on the right side, and it is the fifth intercostal space on the left side. And we got a sternocostal surface or anterior surface of the heart, which is related with the sternum anteriorly and the ribs, hence the name sternocostal surface. Though it will be having all the 4 chambers of the heart represented, but basically it is the right ventricle here, as can be seen in the next diagram. So as suggested, the anterior sternocostal surface of the heart is having all the 4 chambers represented, but basically it is more of the right ventricle there, related with the sternum and the ribs, sternocostal surface. Now, if you say that is the right ventricle, this is the right atrium here. And if that is the right atrium, then this is right atrioventricular groove here, which is also called right coronary sulcus. There runs the right coronary artery. So that is the right coronary artery running in the right coronary sulcus, which is the right atrioventricular groove here, and it is a branch of the ascending aorta. It will keep running in the sulcus anteriorly as well as then go posteriorly behind the heart. Now on the other side, you can see the left ventricle as well. And between the 2 ventricles will be interventricular septum, having an interventricular groove, which is anterior interventricular groove. And there you have anterior interventricular artery running. Now that anterior interventricular artery is a branch of the left coronary artery, which itself is a branch of the ascending aorta here. It basically gives 2 branches. One is descending down, which is the left anterior descending artery, also called as anterior interventricular artery, running in the anterior interventricular groove, supplying anterior 2/3 of the interventricular septum. And what about the other branch of the left coronary artery? That is a branch going around the heart called circumflex artery, running in the left coronary sulcus. This other branch of the left coronary artery, which is called as the circumflex branch of left coronary artery, is running in the left coronary sulcus, not only anteriorly, but it will go posteriorly as well. This is called as the left coronary sulcus or the left AV groove because it is separating left atrium, which is chiefly behind the heart, posterior to the heart, and the left ventricle, which is not only seen anteriorly but also posteriorly. And it is the left coronary sulcus having the branch of left coronary artery called circumflex artery going posterior to the heart. Now this AIVA in the AIVG is followed by the branch, a vein which is called great cardiac vein. This great cardiac vein, which begins near the cardiac apex, is ascending up in the anterior interventricular groove along with anterior interventricular artery. Then it will be running in the left coronary sulcus along with the circumflex artery and go posteriorly to drain into the coronary sinus of the heart, which lies in the coronary sulcus but posteriorly. The coronary sinus which lies behind the heart also receive small cardiac vein, and the small cardiac vein, which is continuation of right marginal vein on the anterior aspect of the heart. The right marginal vein will continue as the small cardiac vein and will be running in the right coronary sulcus along with the right coronary artery but posteriorly, so that the small cardiac vein can drain into coronary sinus which lies posteriorly. So let us look at the coronary sinus now at a posterior view of the heart. Now this is the posterior view of the heart, which is having two surfaces. One is called as the base of the heart, or it is called posterior surface of the heart, which is chiefly the left atrium and partly the right atrium. So both the atria will form the base of the heart or the posterior surface of the heart. Now, what about the inferior diaphragmatic surface of the heart? It is both the ventricles and chiefly the left ventricle, partly the right ventricle. And both the ventricles are sitting on the central tendon of the diaphragm. So they are called as inferior diaphragmatic surface of the heart, chiefly constituted by the left ventricle and partly by the right ventricle, having a posterior interventricular groove on the interventricular septum there, having the posterior interventricular artery, and which is a branch of right coronary artery. So this posterior interventricular artery, which is usually a branch of the right coronary artery, is running in the posterior interventricular groove supplying posterior 1/3 of interventricular septum, whereas the anterior 2/3 of the septum was supplied by AIVA in the AIVG, that is anterior interventricular artery in the anterior interventricular groove supplying anterior interventricular septum. And as we suggested, it is the left ventricle chiefly plus the right ventricle together forming inferior diaphragmatic surface on which you are finding that this artery was running, the PIVA. It is followed by a vein which is called as the middle cardiac vein. Now that the middle cardiac vein, which is following the PIVA in the PIVAG, is going to drain into the coronary sinus. And the coronary sinus, which is in the coronary sulcus on the posterior view of the heart, is going to drain this blood into the posterior smooth part of the right atrium here. And then this coronary sinus receives two more veins, major veins. One of them is coming from the right side and it is called as the small cardiac vein. And if you remember, the small cardiac vein is following the right coronary artery in the right coronary sulcus posteriorly to drain into the coronary sinus, which lies in coronary sulcus posteriorly. And it is also receiving the great cardiac vein coming from the left side. Now that great cardiac vein which is coming from the left side, it is actually following circumflex artery in the left coronary sulcus posteriorly and then drain into the coronary sinus posteriorly. And here you can see the left atrium, which is having the opening of the 4 pulmonary veins which bring the oxygenated blood from the lung into the heart. And this is the right atrium, which receives the deoxygenated blood of the body via the superior vena cava, body above diaphragm, inferior vena cava, body below diaphragm, into the right atrium. Now let us talk about the right coronary artery and left coronary artery branches in detail. As we suggested, it is the ascending aorta which is giving both the branches, maybe right coronary artery or left coronary artery. So let us first focus upon the right coronary artery. Here is ascending aorta giving right coronary artery, which is running in the right coronary sulcus anteriorly as well as posteriorly. There's the posterior course of the right coronary artery in the coronary sulcus. Anteriorly, it is giving a branch to the SA node, and that is called as the SA nodal artery. Remember, SA nodal artery is a branch of the right coronary artery in most of the population, the AV nodal artery. This AV nodal artery, which is given by the right coronary artery running in the right coronary sulcus posteriorly, is usually a branch of right coronary artery in most of the population, though in some people it may be coming from the left coronary artery as a variation. So SA nodal artery, AV nodal artery are usually branches of right coronary artery, though they may come from left coronary artery as a variation in some people. SA nodal artery is given anterior, AV nodal artery is given posterior. And posteriorly, you can see one more branch, which is called as the PIVA in the PIVG, supplying the PIVS. That is, posterior interventricular artery is usually a branch of the right coronary artery running posteriorly and supplying the posterior 1/3 of the interventricular septum. This PIVA determines the cardiac dominance, and 65% people have right cardiac dominance because they have the PIVA coming from right coronary artery. Whereas the 10% people have left cardiac dominance because in that case, the PIVA will be a branch of the left coronary artery. And in 25% people, there's a codominance, means you have multiple PIVA, one PIVA coming from the right coronary artery, another PIVA coming from the left coronary artery. We have seen the 65% right cardiac dominance feature here. We will now talk about the 10% people having left cardiac dominance there. The suggested is the ascending aorta only, which is giving the left coronary artery as well. And it is giving two branches, one descending down the heart, one is going around the heart. The one which descends down the heart is called the LAD, left anterior descending artery. The other name is anterior interventricular artery, running in the anterior interventricular groove, supplying anterior 2/3 of the interventricular septum. And it also supplies anterior wall of the left ventricle and partly anterior wall of the right ventricle also. The other branch is circumflex artery, which is going around the heart in the left coronary sulcus posteriorly. And as the circumflex artery go posteriorly, in 10% people, it may be giving PIVA. Now, if the circumflex artery, which is a branch of the left coronary artery, is giving PIVA, then it will be 10% of the population having left cardiac dominance. In that case, the PIVA is a branch of the circumflex artery, which itself is a branch of the left coronary artery. Understand that the circumflex artery is going to supply lateral surface of the left ventricle there. Now, when it comes to the conduction system, arterial supply, we have already mentioned that the acinodal artery, avinodal artery are usually branch of the right coronary artery. That is the proximal path of conduction system, chiefly depending upon the right coronary artery. Whereas the distal part of conduction system, which is lying on the interventricular septum, is chiefly depending upon the left coronary artery. It includes the AV bundle of Hayes and also the bundle branches. There is the right bundle branch here and the left bundle branch here running on the interventricular septum, but more anteriorly, since the distal part of conduction system, which is the AV bundle of Hayes and the bundle branches, run more anteriorly on the interventricular septum. They'll be supplied by AIVA, branch of the LCA, which is anterior interventricular artery, branch of the left coronary artery. Now, if you say that AV bundle of Hayes and the right bundle branch, left bundle branch are running more anteriorly on the interventricular septum and are under the anterior interventricular artery, branch of the left coronary artery, understand a part of the AV bundle of Hayes is partly supplied by the right coronary artery as well. So, AV bundle of Hayes has double supply, though major supply is from the left coronary artery branch, but a little bit supply is from the right coronary artery as well. Though, practically speaking, the proximal part of conduction system, which is SA node, AV node, is under right coronary artery territory, and the distal part of conduction system, which is bundle of Hayes and bundle of branches, are under left coronary artery territory. We understand that in triple vessel disease, there can be 3 vessels involved. 50% of the population in the patient will be the LAD, which is blocked. 30% people have RCA block, right coronary artery, and 20% people have a block in the circumflex artery. And some people can have all the 3 arteries blocked. If it is the LAD plus RCA plus circumflex artery block, then you will say triple vessel disease. Now understand, if it is the LAD blocked here, which is also called anterior interventricular artery, then there will be ischemia in the anterior wall of the right and left ventricle and also anterior 2/3 of interventricular septum, as you can see here. So anterior 2/3 of the septum is having ischemia, anterior wall of the left ventricle having ischemia, and partly the right ventricle as well. It is a cut section of the ventricles there, showing the interventricular septum between the left ventricle and the right ventricle. Then what will happen if I have a block in the right coronary artery? If you have a block in the right coronary artery, the right chambers of the heart will be compromised, and also the PIVA, posterior interventricular artery, will have compromised blood flow, hence leading to ischemia in the posterior one-third of the interventricular septum, and also the posterior wall of the left ventricle. As it is running in this territory, the PIVA, posterior interventricular artery branch of the right coronary artery. If the right coronary artery is blocked, there is compromised blood flow in the posterior interventricular artery, and the posterior one-third of the interventricular septum compromised, and also the posterior wall of the left ventricle compromised. Though it will also be compromising the right ventricle there, as the right coronary artery has been blocked there. And what will happen if I have a block in the circumflex artery? Then the lateral surface of the left ventricle will be compromised. Then how come the anterior wall of the left ventricle surviving? Because that is still being supplied by AIVA, anterior interventricular artery branch of the left coronary artery. And how come the posterior wall of the left ventricle surviving? The posterior wall of the left ventricle surviving because that is the territory of posterior interventricular artery running here, posterior to interventricular septum. So a block in the circumflex artery will compromise only lateral wall of the left ventricle there. Presently, we are looking at the venous drainage of the heart, and basically all the veins in the heart are going to drain into the coronary sinus, which is in the coronary sulcus, running posteriorly. Now, some of the veins are starting anteriorly. For example, this is the right marginal vein here. And the right marginal vein is going to become small cardiac vein, which will be running along with the right coronary artery in the right coronary sulcus posteriorly, and then drain into the coronary sinus posteriorly. Then here we have got the middle cardiac vein, which is actually running on the posterior view of the heart, along with the posterior interventricular artery in the posterior interventricular groove supplying the posterior interventricular septum, and then drains into the coronary sinus posteriorly. And then we have got the great cardiac vein. The great cardiac vein, which begins near the apex of the heart, ascends up along with the anterior interventricular artery in the anterior interventricular groove, and then turns posteriorly. There it will be following the circumflex artery in the left coronary sulcus to the posterior aspect of the heart. And as it enters the coronary sinus posteriorly, the coronary sinus has received blood from numerous veins. But there are some veins like anterior cardiac veins, which do not drain into the coronary sinus. They drain directly into the anterior wall of the right atrium. So if there is a coronary sinus thrombosis, then some of the veins will be dilated, which are the small cardiac vein, middle cardiac vein, and the great cardiac vein, but not the anterior cardiac vein, because they do not drain into coronary sinus. They drain directly into the anterior wall of the right atrium. And where is the coronary sinus draining? Coronary sinus is draining into the posterior wall of the right atrium. Now let us look at the blood flow throughout the four chambers of the heart. You'll find that the body of the diaphragm drains the blood into superior vena cava, and the body below the diaphragm drains the blood into inferior vena cava. And this blood of inferior vena cava, superior vena cava will enter the right atrium. From the right atrium, this blood will be coming to right ventricle, and it cannot go back into right atrium, prevented by a tricuspid valve having three cusps, right atrioventricular valve, preventing backflow of blood from the right ventricle to right atrium. There are three cusps and there are three papillary muscles: anterior papillary for anterior cusp, posterior papillary posterior cusp, and the septal papillary muscle for septal cusp, though they are attaching to all the three eventually. Now this blood which has entered the right ventricle has to go into the pulmonary trunk towards the lungs, and as the blood is going towards the lungs, the blood will be oxygenated and sent back into the pulmonary veins, into the left atrium. Now, as the blood comes back into the left atrium, it will be pushed into the left ventricle. And it cannot go back because it is prevented by the bicuspid valve, which is called mitral valve. Mitral valve will be left atrioventricular valve and preventing the backflow of blood into the left atrium. It will have two cusps and there are two papillary muscles. There is anterior papillary muscle attaching to anterior cusp and posterior papillary muscle attaching to posterior cusp. Now this blood which is in the left ventricle will be pushed into the aorta, which is passing behind the pulmonary trunk here. So as the blood is coming from the left ventricle into the aorta, that will be distributed to the systemic circulation. Now let us magnify the right atrium ventricle and the left atrium ventricles to have more details of the chambers. This is the right atrium here, having the opening in the posterior smooth wall, which are three in number. That is the opening of superior vena cava, and then you have opening of inferior vena cava, and there is also the opening of coronary sinus. Now, the blood which is coming into the right atrium will go to the right ventricle, which is having the tricuspid valve, having three cusps. The cusps are called as anterior, posterior, and the septal cusp. There will be three papillary muscles also, and these papillary muscles are having some chordae tendineae, and with the help of those chordae tendineae, the papillary muscles are holding on to the cusp of the tricuspid valve and preventing its out ballooning towards the atrium. Basically, these cusps are preventing the backflow of the blood from the ventricle towards the atrium. You'll find that the anterior papillary muscle has a moderator band, which is also called as the septomarginal trabeculae, and it contains a part of the right bundle branch coming from the interventricular septum and directly reaching the wall of the right ventricle. Now, this is the interventricular septum, the muscular portion, that is the membranous portion. This is the thick muscular portion, and that is the thin membranous portion of the interventricular septum between the two ventricles. You can see the left atrium also receiving the oxygenated blood from the lung by the pulmonary veins and pushing into the left ventricle. Backflow is prevented by the mitral valve, and mitral valve has two cusps, anterior posterior, having two papillary muscles also. The anterior papillary muscle in the left ventricle and the posterior papillary muscle as well, sending some chordae tendineae to hold on to the cusp of the mitral valves. Now let us magnify the right atrium for details. This is a schematic diagram for the right atrium here, having three openings posteriorly. And as you magnify it here, you can see that is superior vena cava opening. And then you can also see inferior vena cava opening. The third opening is the coronary sinus. Now the blood which came into the right atrium posterior smooth wall, which is sinus venerum, embryologically, there is a crista terminalis in the right atrium, which is separating the rough anterior wall with the musculi pectinati and the rough trabeculator portion, embryologically coming from primitive atrium, whereas the sinus venerum is the absorbed right horn of the sinus venosus. Embryologically, there are few vena cordis minimis, the small veins which keep opening into the all of the four chambers of the heart indirectly, means they are not going to enter the coronary sinus. And this is the limbus fossa ovalis, which is present on the right septum or the septum secundum embryologically, whereas at the floor of the fossa ovalis, you will see that it is the septum primum, which is on the left side septum. And then you can see the blood which was in the right atrium goes to right ventricle, passing the tricuspid valve, having three cusps. This is the tricuspid valve and the opening into the right ventricle. The cusps are called anterior, posterior, and the septal cusp. Now we are looking at the three cusps here, and it is the interior of the right ventricle. Let us magnify that now. You can see this is the right atrial chamber, this is the right ventricle, and this is the right AV valve, the tricuspid valve, having one anterior cusp and one posterior cusp, and there is septal cusp, which is related to the interventricular septum. There are three papillary muscles also. The anterior papillary muscle, which is having the septomarginal trabeculae or the moderator band there, and the posterior papillary muscle and the septal papillary muscle. They are sending chordae tendineae to hold on to the cusp of the tricuspid valve, preventing their out ballooning towards the right atrium. And between the right ventricle and pulmonary trunk, we have a supraventricular crest. Now we are looking inside the left ventricle here, and partly the left atrium as well. Between the two, you have the mitral valve, which is bicuspid valve, or the left atrioventricular valve. It is having one anterior cusp with anterior papillary muscle, and then you have the posterior cusp of the mitral valve with posterior papillary muscle. The mitral valve is preventing the backflow of the left ventricle blood into the left atrium, and the blood should go towards the aortic vestibule. Aortic vestibule is the smooth outflow tract of the left ventricle, embryologically derived from the bulbous cordis. And the aortic valve or the pulmonary valve are having three cusps each. Now we are looking at the front view of the lungs, and the right lung will have two fissures, three lobes, whereas the left lung has only one fissure and two lobes. That is the horizontal fissure in the right lung, and this is the oblique fissure. Bounded between the two is the middle lobe of the right lung, and then we have the right upper lobe and right lower lobe. As we are talking about the left lung has only one fissure, which is called oblique fissure, and there are only two lobes, left upper lobe and left lower lobe. Now we want to see the bronchopulmonary segments in each lung. Generally spoken, 10 bronchopulmonary segments on the right lung and 10 on the left, but it is usually mentioned by Gray's Anatomy that there are 9 in the left lung. One of the BPS is missing. Now, which BPS is missing? Let us find out. Understand that there's a difference between the right principal bronchus and left principal bronchus. The right principal bronchus is short in length, wide in lumen, and more vertical. So there are more chances of foreign bodies entering the right lung as compared with the left. So the right principal bronchus is short, length, wide lumen, and more vertical, leading to more chances of foreign bodies entering the right lung. Now this is the first degree bronchus, the principal bronchus. Then you have the second degree bronchus, which are called as lobar bronchus because you have the upper lobe, middle lobe, and lower lobe. So there will be 3 second degree bronchus on the right side, and there will be 2 second degree bronchus on the left side for left upper lobe and left lower lobe. Then comes the tertiary bronchus. The tertiary bronchus is going to supply 1 unit of the lung, which is called bronchopulmonary segment. And there are 10 BPS on the right lung and 10 BPS on the left lung, hypothetically, but usually we find only 9. Now let us talk about the BPS in the next diagram. As you would find that the right upper lobe will have 3 BPS. There's one apical and one anterior posterior in the right upper lobe. And in the right middle lobe, you will have 2 BPS, lateral and medial. And the remaining 5 are present in the right lower lobe. And they are named as 1 apical and 4 basal. Remember, the apical is also called superior BPS and the basal are called anterior, posterior, medial, lateral, basal. It is the posterior basal which is the most dependent location in the erect posture. If a patient is in sitting standing posture aspirate, then it will be mostly in the right lung, and that too in the posterior basal of the right lower lobe, because that is the most dependent location in erect posture, having aspiration pneumonitis. As we said, this is the first degree bronchus, the principal bronchus. This is the second degree bronchus, which is the lobar bronchus, and these are the tertiary bronchus. They are also called segmental bronchus, and they are going to supply the 1 unit of the lung, which is called bronchopulmonary segment. And we have 10 of them here on the right side, the 10 tertiary bronchi. Now, what about the left lung? In the left lung, there is a left upper lobe and the left lower lobe. And in the left upper lobe, let us count the BPS. In the left upper lobe, you will find there is 1 apical and 1 posterior and anterior, just like the right upper lobe. But then we will find that sometime there may be a fusion of the two. That is apical and posterior becoming 1 BPS, which is called apico-posterior. So there can be only 2 BPS instead of 3 as a variation in some people. Then since the left lung do not have a middle lobe, there is a representing lobe which is the lingula of the left lung, and lingula which represent the middle lobe as compared with the right middle lobe. It is the lingular lobe having superior inferior lingular BPS. And they are obviously a part of the left upper lobe, as we don't have any middle lobe in the left lung. Then how many BPS in the left lower lobe? Obviously, you have 5 here, so 5 there, which are 1 superior, also called as apical, and 4 basal. And the basal are called anterior basal, posterior basal, medial basal, lateral basal. But as I suggested that in Gray's Anatomy, we will find in the left lower lobe, there are only 3 basal, usually in the population. How come? Because anterior and basal are combined together to form anteromedial basal. Whenever you find the term anteromedial basal, it means anterior basal because the medial basal is missing in the left lung. Now, why the medial basal is missing in the left lung? Let us find out. But usually the medial basal will be missing. So you have only anterior basal, which is renamed as anteromedial basal. And then you have lateral basal, you have the posterior basal as well. So there can be 10 BPS, or there can be 9 BPS, or there can be 8 BPS. When will you have 8? When you have the fusion of apical posterior as apico posterior and anteromedial as anterobasal. So you will have total 8 of them. But usually we have apical and posterior separate. It is the medial basal which is missing. So in fact there are total 9 in most of the population as per Gray's Anatomy. Let us discuss it more now. As you can make out, this is the front view of the right lung showing 3 fissures and the 2 lobes plus 10 BPS. Here is the horizontal fissure. Here is the oblique fissure which extends upward, and then you have the middle lobe here. This is the right upper lobe, this is right lower lobe. There you have the right upper lobe having 3 BPS, which is the apical, anterior and posterior. There's the middle lobe having the medial and lateral BPS. And this is the right lower lobe having the 5 BPS. There is 1 apical and 3 basal which are evident. There is the 4th basal which you cannot see, the posterior basal. It will be seen posteriorly. So there is medial basal and the anterior basal and the lateral basal and the posterior basal. Total 5 here, plus 2, 7, plus 3, 10 in the right lung. Now understand that if there is an aspiration in the sitting standing posture, which is erect posture, then it will be mostly the right lung involved, and that too posterior basal, which you can see now because you're looking from the posterior aspect. This is the right lung and posterior aspect. So the patient is upright and basal segments are most dependent. And it is this area which is getting involved. It is the right lung, lower lobe, posterior basal segment. The posterior basal segment of the right lower lobe is the most dependent location in the erect posture having aspiration pneumonitis. Whereas if the patient was supine, then the gravity will pull it to the other BPS. These are mostly coma patient or post-anesthesia recovery phase patient, and the aspirates are found in the upper lobe or lower lobe. Mostly it is the apical BPS of the right lower lobe, apical BPS of right lower lobe, or it is the posterior BPS of the right upper lobe, posterior BPS of the right upper lobe. If you have to choose between the two, if the patient was supine, the most dependent lobes are these two, and in which also if you have to choose, this is the first answer. Apical BPS of right lower lobe is a better answer than the posterior BPS of right upper lobe for aspiration pneumonitis in a supine patient. Now we are looking at the left lung anterior view showing the oblique fissure and 2 lobes, that is left upper lobe and left lower lobe. So that is the oblique fissure, and we can see the left upper lobe is having some BPS, like there's the apical, there is the anterior and posterior, and then we have the superior inferior lingular also. And what about the left lower lobe? There will be 1 apical but only 3 basal, because the anterior basal and the medial basal are combined, or in fact the medial basal is missing. And what you call anterior medial basal is in fact the anterior basal. Can you tell me why the medial basal is missing? Let us find out. But then there are only 3 basal which are called as anterior basal, lateral basal and posterior basal. So there are 9 BPS out of 10 in most of the population, and medial basal is missing, which is also called cardiac BPS of the lung, and it is present only on the right lung. It happens because the left lung is being encroached by the heart from the medial direction. As you can see here, the heart is encroaching the base of the left lung from the medial direction. It needs some space, and that space is provided by disappearance of 1 BPS in the left lung. That is medial basal, which is also called cardiac BPS. And cardiac BPS is present only on the right lung. It is absent from the left lung. So left lung has only 9 BPS out of 10 there, as you can see in Schwartz surgery diagram as well. As I'm showing you the diagram of Schwartz surgery, you can see medial basal is missing in the left lung, which is number 7 shown on the right lung medially, but is absent from the left lung medially. Now we're looking at the more detail of a BPS. This is 1, 2, 3 bronchopulmonary segments, and how do you define them? They are a part of lung, unit of lung to be aerated by 1 tertiary bronchus. This is also called segmental bronchus. So there is 1 segmental bronchus or tertiary bronchus, followed by a segmental branch of the pulmonary artery, which will bring the blue blood, the deoxygenated blood from the heart, and the segmental branch of bronchial artery, which will bring the oxygenated blood to the lung. So here you can see 1 artery is shown blue, which is pulmonary artery, and 1 is shown red, which is bronchial artery. Whereas the pulmonary veins are intersegmental in nature. As you say that the intersegmental plane will have pulmonary veins, why are you showing them red color? Because they carry the oxygenated blood from the lung to the heart. Let us explain the details now. As the heart is sending the oxygenated blood in the pulmonary artery into the bronchopulmonary segments, it will be receiving some oxygen from the alveoli in the lungs. And then the oxygenated blood will enter the pulmonary veins and go towards the heart. Pulmonary veins are intersegmental in nature, And one pulmonary vein can drain more than 1 BPS since they are intersegmental. And since they are intersegmental, you can follow them as a surgical plane and remove one of the segment from another segment, which is called segmentectomy. As a surgeon, you can follow the pulmonary veins to remove a piece of the lung if it was having carcinoma or maybe bronchiectasis involving 1 BPS there. Now we are going to look at the lungs and their hilum, and as you find that the heart is going to send the deoxygenated blood into pulmonary trunk and pulmonary arteries. So one pulmonary artery will enter into the hilum of each lung. Then the lungs will be oxygenating the blood and sending back into the pulmonary veins. There will be 2 pulmonary veins on either side from each lung. You will also find that the trachea will come and divide into bronchus, and there will be a right principal bronchus, left principal bronchus. Let us now look at those details. As you can make out, this is the blue color pulmonary trunk, as it is carrying the deoxygenated blood from the heart and dividing into right and left pulmonary arteries. These pulmonary arteries are going to enter the hilum of each lung. As you see now, the lungs will be sending some veins back towards the heart, and here is the superior inferior pulmonary vein, not only on the left lung, but also on the right lung. So 2 pulmonary veins, superior inferior, they are more anterior as compared with the artery, because the veins are thin, they better stay more superficial. Arteries have thick wall, so more posterior. Still more posterior is the thickest wall, which is the bronchus. There will be right principal bronchus most posterior, and there will be left principal bronchus most posterior. The arrangement of structure is vein, artery, and bronchus, anterior to posterior. What about superior to inferior? Well, notice that most superior is the artery, and below that is the bronchus, and below that is the vein, which is not very evident here. So let us look at the medial view of the lung hilum as such, on the left lung as well as the right lung. Here we are removing the left lung, and we are looking from the medial aspect of the mediastinum. So that is the heart seen from the left side after removing the left lung. To the left side of midline, we have the descending thoracic aorta moving on the posterior aspect of the heart and as well as the lung. And then you can make out the pulmonary trunk giving pulmonary artery, which carries the deoxygenated blood to the lung, which you have removed. Lung will be sending some oxygenated blood back towards the heart. But the 2 pulmonary veins, which are here, the superior pulmonary vein and inferior pulmonary vein would like to stay more anterior as compared with the pulmonary artery. But the most posterior will be bronchus. This is the bronchus. So vein, artery, and bronchus, anterior to posterior. Also understand, there's a mnemonic to remember for the arrangement of the structure superior to inferior. You can remember Atal Bihari Vajpayee. Atal A for the artery, pulmonary artery. Bihari is the bronchus in the middle, and vein is the Vajpayee. Atal Bihari Vajpayee, artery, bronchus, and the vein. Superior to inferior. Now that arrangement you will find on the left lung and also the right lung, but on the right lung there is one additional finding. What is the additional finding? Let us see that. Also notice that as you are removing the left lung will have some impression. The same way as you saw here, you can see there. You will find this is the arch of aorta and the descending thoracic aorta making impression on the left lung. That is the arch of aorta impression on the mediastinal surface of the left lung. That is for the descending thoracic aorta on the posterior aspect of the lung. This is the hilum of the lung. So as we said, Atal Bihari Vajpayee, artery is more superior. And if you say artery more superior, then what is below that? The bronchus. The bronchus is in the middle, and more inferior are the pulmonary veins, the superior inferior pulmonary veins. So Atal Bihari Vajpayee, the hilum of the left lung. And also notice that left lung will have the left ventricle impression here. That is for the left ventricle of the heart making an impression on the left lung. Mediastinal surface. This is the anterior border of the lung, and that is the posterior border of the lung. The inferior diaphragmatic surface of the lung, which is sitting on the diaphragm there, inferiorly, also called as the base of the lungs on the diaphragm. Now, as you compare the right hilum and the left hilum of the lungs, in the left lung, you have seen that it is artery more superior, bronchus in the middle, and veins are more inferior. The same arrangement you can see on the right lung as well. There is one difference. There is one eparterial bronchus, one additional bronchus which is above the artery. And that is the only thing which is additional, otherwise same way as the left lung. So it is Atal Bihari Vajpayee, but there is one additional thing. There is one more Bihari above the Atal. It's called epiarterial bronchus. Otherwise, it is the same way that we have got artery, bronchus and vein, superior to inferior. Now, right lung will have the right atrium in relation on the mediastinal surface. And if you say it is right atrium related here, there will be superior vena cava, inferior vena cava impression. And not only superior vena cava, inferior vena cava impression, which enter into the right atrium on the mediastinal aspect of the right lung, you can also see the azygous vein is arching over the hilum of the right lung. The impression of the azygous vein coming from posterior to anterior going to enter the superior vena cava before the superior vena cava enters the right atrium. These are all impressions on the mediastinal aspect of the right lung. On the left lung, we already have seen that will be the left ventricle in the arch of aorta, having an impression over the hilum of the left lung. Then we will be descending thoracic aorta, running on the posterior aspect of the hilum of the left lung, just the impression of the aorta. Let us look at the surface marking of the lungs and the pleura for the right and the left lung. They are almost same as you follow the inferior border, but there is one difference between the two. Let us first focus upon the right lung and the right pleura here. As you look at the pleura inferior border on the right lung, it will be starting at the 6th rib in the mid-sternal line, and it reaches the mid-clavicular line, 8th rib there, then goes to the mid-axillary line. There'll be 10th rib, and as you go posteriorly paravertebral line, it will be 12th rib. So you can remember like 6, 8, 10, 12. 6th rib, it is in the mid-sternal line, the beginning of inferior border of pleura. 8th rib, it is the mid-clavicular line, and 10th rib, it is mid-axillary line, and 12th rib, it is paravertebral line posteriorly. We cannot see the posterior thing here, but we have a diagram to discuss that. So what about the lung? Lungs also start at the 6th rib in the mid-sternal line for the right lung. But after that, the lungs stay 2 rib higher, 2 rib higher, 2 rib higher. Means it will be starting at the 6th rib, but again it is 6th rib and 8th rib and the 10th rib. It means the lungs are 2 rib higher, 2 rib higher, 2 rib higher at the mid-clavicular, mid-axillary and paravertebral line. But why the lungs are 2 rib higher? Because the lungs need to expand in the pleural space. So that space is empty normally, but in deep inspiration that will be filled with the lungs. Now we'll have one other diagram also to discuss that, but what is the difference between right and left lung? Now let us look at the left pleura also, which is actually having the same marking as the right lung, but there is only one difference. It is understood that the heart is encroaching towards the left lung from the medial direction, so the left lung is having a cardiac notch, and that is why the pleura is also moving away from the mid-sternal line at the costal cartilage rib number 4. So that is the only difference, that the right pleura leaves the mid-sternal line at the 6th rib, but the left lung leaves the mid-sternal line at the 4th rib. Otherwise, beyond that, it is the same marking, which is, as you say, this is the 6th rib, it will be at the 6th rib only. And after that, 8th rib, 8th rib. And after that, 10th rib, 10th rib. And after that, posteriorly 12th rib and 12th rib. Can we write it down for the left lung here now? Yes, let us do it. For the pleura, you will write 4, 6, 8, 10, 12. What does that mean? The mid-sternal line on the left side, the pleura is at the 4th rib, leaving there. And at the 6th rib, it will be at the parasternal line. And then it is 8th rib at the mid-clavicular line, and then it is 10th rib in the mid-axillary line, and the 12th rib posteriorly paravertebral line. So it is just like 6, 8, 10, 12, 6, 8, 10, 12, same thing almost for the inferior border on both the lung, except one difference, that it is leaving the sternum at 4th rib there due to some cardiac notch actually. And what about the lung then? Lungs will stay 2 rib higher, 2 rib higher, 2 rib higher as the right lung, the left lung is same. Now let me show you the actual surface marking of the pleura in a separate diagram. As you start marking the pleura, you have to go supraclavicle. It is the apex of the lung covered by cervical pleura. So as you are going supraclavicle, which is on the medial end of the clavicle, it is around 2.5 centimeter above the medial 1/3 of the clavicle, which is the cervical pleura. And you come to the mid-sternal line. As you keep coming to mid-sternal line, you will come to the 6th rib here and inferior border we were marking. So it is at the 6th rib in the mid-sternal line on the right side, and then beginning of the inferior border. 8th rib, it is mid-clavicular line, and 10th rib, it is mid-axillary line, and then the 12th rib paravertebral line posteriorly. The inferior border of the right lung pleura is same as the left pleura with one minor difference. What is that minor difference due to? Due to the cardiac notch of the lung. So we can start here again. It is said medial end of the clavicle, 2.5 centimeter higher in the neck region is the cervical pleura, apex of the lung, being covered by that. And then you can come mid-sternal line. Now as you come to mid-sternal line, at the 4th rib you have to go away from mid-sternal line. That is due to the cardiac notch in the lung. So pleura is also deviating along with the lung. But after that it is the same way as the right pleura, means the inferior border begins at the 6th rib on both the sides. Though this is mid-sternal line, this is parasternal line on the left lung, but it is 6th rib. And what about mid-clavicular line? In the mid-clavicular line, it is 8th rib. Like here, it is 8th rib. And in the mid-axillary line, it is 10th rib, as it is here. 10th rib, 10th rib. And in the paravertebral line, it is 12th rib, as it is here, 12th rib. So inferior border is similar. 6, 6, 8, 8, 10, 10, 12, 12. Then what is different? The anterior border. The anterior border of the pleura on the right lung reaches the 6th rib, mid-sternal line, but on the left side it will leave the mid-sternal line at the 4th rib and will be at the 6th rib here, but parasternal line. That is the only difference you got there. Otherwise similar here as there. And what about the lung? Lungs are 2 rib higher, 2 rib higher, 2 rib higher on both sides. At which point? At the mid-clavicle, mid-axillary and paravertebral line. So what should I remember for the inferior border? You should remember a simple thing. 6, 8, 10, 12. Inferior border. 6th, it is the sternal relation. 8th is the mid-clavicular line. 10th is the mid-axillary line. And 12th is the paravertebral line for both the pleura, maybe right or left. Inferior border. Now, talking about the surface marking of the lung, let us mark the horizontal fissure. Let me zoom this area now. As you will see, the horizontal fissure, I have to start at the 5th rib in the mid-axillary line and come to the 4th rib at the anterior border of the lung. And what about the oblique fissure? Oblique fissure starts posteriorly and is coming anteriorly. And where it come anteriorly? Because oblique fissure is on both sides, you can talk about the both sides. It is coming from the 5th rib in the mid-axillary line and reaches the 6th rib in the mid-clavicular line. That is the oblique fissure of the right lung as well as left lung. Can you tell where the oblique fissure begins? It is on the posterior side. Where on the posterior side? Let us see. You can see the oblique fissure on both the lung seen from the posterior side begins at spinous process of T3 vertebra, then moves obliquely and goes anteriorly. So that is the beginning of the oblique fissure. Posteriorly, yes, then it goes anteriorly. And what is the level of lungs posteriorly? It is 2 rib higher to the pleura. What does that mean? Pleura was reaching 12th rib level and the lung will remain 2 rib higher in the paravertebral line. That means at the 10th rib and 10th rib. So lower border of the lungs is at the 10th rib posteriorly. Yes, that's the point. 2 rib higher to the pleura. And as the oblique fissure starts here, can you tell me the course laterally? Yeah, let us zoom this now. As the oblique fissure is coming, it will be coming from the T3 spinous process posteriorly and reaches the 5th rib mid-axillary line and then will go anteriorly to the anterior border while passing the 6th rib in the mid-clavicular line. So that is the course of the oblique fissure. That was the horizontal fissure, which we said will come from the 5th rib in the mid-axillary line to the 4th rib in the anterior border of lung. Then what about the left lung? Left lung is the similar fashion. You can see the oblique fissure starting at the T3 spinous process posteriorly and then coming anteriorly to reach the sixth rib in the mid-clavicular line, just like the right lung, dividing the left lung into left upper lobe and left lower lobe. Whereas here you have the right middle lobe, which is between the horizontal fissure and the oblique fissure. And then you have right upper lobe, right lower lobe. You can notice that when we are elevating our arms for overhead abduction, the medial border of the scapula is lying along the oblique fissure of the lung on both sides. And if you want to do percussion here, then what you do is medial to the medial border of the scapula, you are at the apex of the lower lobes, maybe this side or that side. So if there is a collection in the apical BPS of the right lower lobe, which I told is seen in a case of supine patient, maybe coma patient or recovery phase post-anesthesia, most common site of apical BPS of right lower lobe, medial to medial border of the scapula, posteriorly. As we talk about the mediastinum, which is a median septum between the two lungs there, having the structure called heart and the related vessels and some of the other viscera, let us look at the more detailed structure. We'll find that there is a superior mediastinum and there is an inferior mediastinum. The heart lies in the inferior mediastinum, the median septum between the two lungs. Inferior mediastinum itself will have three parts. There is anterior, middle, and posterior mediastinum. The heart is actually in the middle mediastinum. So there'll be a space in front, and that is anterior mediastinum, space behind the heart, which is posterior mediastinum. Let us look at that in a side view sagittal section then. Here we are putting a sternal plane, which is at the disc between T4-5 vertebra and touching the sternum bone at manubrium-sternal junction, where comes the second costal cartilage. There's the manubrium bone and there's the body of sternum, and the angle between the two is 163 degree. That is the sternal angle of the Louis. There's a sternal plane as well, dividing the mediastinum to superior inferior mediastinum. And the inferior mediastinum itself has three parts. The heart in the middle mediastinum, a space in front of the heart and behind the sternum is called as the anterior mediastinum. There's a space behind the heart and in front of the vertebra is the posterior mediastinum. As you see, posterior mediastinum is quite long as compared with anterior mediastinum. Posterior mediastinum starts at the T5 vertebra, reaches the T12 vertebra, and contain the descending thoracic aorta. If descending thoracic aorta is in the posterior mediastinum, then where is the ascending aorta? The ascending aorta lies in the middle mediastinum along with the heart. Then where is the arch of aorta? Arch of aorta lies in the superior mediastinum, behind the bone manubrium there. And where is the descending thoracic aorta? Descending thoracic aorta lies in the posterior mediastinum with the tube which is called esophagus. So this esophagus, which is lying in the posterior mediastinum along with the descending thoracic aorta, is also present in the superior mediastinum. And when the esophagus is in the superior mediastinum, it is sandwiched between trachea anterior and vertebra posterior in relation to the upper four thoracic vertebra. The esophagus, which is in the superior mediastinum, then comes to the posterior mediastinum and then passes to the diaphragm. At the T10 vertebra, there is a muscular opening for the passage of esophagus and become abdominal esophagus, then become continuous with the stomach. Trachea lies in the superior mediastinum and is bifurcating at the sternal plane, which is also called sternal angle of the Louis, and giving the right and left principal bronchus. The tracheal bifurcation is at the disc between T4-5. If not found in the option, then you can say trachea bifurcates at the upper border of T5. If that is not found, then you can say it is trachea bifurcating at the lower border of T4. If that is also not found, then if it is deep inspiration, the diaphragm descend down, pull the trachea down, and trachea can be found at the upper border of T6 vertebra. And if that is not found, then it must be a cadaver, a dead individual, and your answer should be T4 vertebra. So let me tell you in a sequence that what should you answer if they're asking tracheal bifurcation. First answer is trachea bifurcates at the disc between T4-5. And if not in the option, then second answer is upper border T5. And if not found, then the third answer is lower border T4. You are basically trying to stay at the level of T4-5 intervertebral disc. If none of the three is present, then maybe the patient has taken a deep breath and diaphragm descent down, pulling the trachea down, and it has reached the upper border of T6 vertebra. So that is the fourth answer. Yes. And what if none of the four are available in the option? Then maybe it is a cadaver they are asking. And in cadaver, what should I answer? Just the T4 vertebra. Then tell me, where is the arch of aorta beginning ending? It is at the costal cartilage number 2. On the right side, it will begin and then reach the costal cartilage number 2 on the left side. What is the extent of the heart in a supine posture? It is T5 to T8 vertebral level. And what if the patient stands? Then the gravity will pull the heart one vertebra down. It will become T6, T9 vertebral level. Plus 1, plus 1. Here it is T5 to T8 and here it is T6 to T9, extent of the heart in standing posture. Now, as we saw earlier, the sternal plane or the sternal angular fluid lie at the disc between T4-5 vertebra, and above that you have the arch of aorta. Not only the arch of aorta but also the trachea lies only in the superior mediastinum, because in the inferior mediastinum it will give the bronchus, left principal bronchus and right principal bronchus. Similarly, remember, pulmonary trunk lies only in the inferior mediastinum, and there only it will give right pulmonary artery, left pulmonary artery in the inferior mediastinum. And as we said, there is the vertebra T4-5, that is the manubriosternal junction. Here you will see the arch of aorta lies behind the manubrium bone, and also you can tell that it is the level of costal cartilage number 2. So arch of aorta begins and ends at the costal cartilage number 2. Beginning is on the right side and the ending is on the left side, but the level is costal cartilage number 2. Maybe it is the beginning or ending. If you have taken a transverse section like a CT scan at the level of the T5 vertebra, then you can see what is called carina. What is carina? It is a cartilaginous spur at the bifurcation of the trachea into two, which is left principal bronchus and the right principal bronchus. And behind the bronchi, you can see the esophagus, sandwiched between the vertebra posterior and the trachea or bronchi anterior. And you can also see pulmonary trunk dividing into the pulmonary arteries, which is the left pulmonary artery and right pulmonary artery. Also seen is the inferior view of the ascending aorta and also the ascending aorta. CT scans are usually seen inferior to superior view. So this is the inferior view of the thorax region and the T5 vertebra, and the arch of aorta will be still higher. Here we are talking about the phrenic nerve, which is having a root value C345 in the cervical region, anterior primary ramus, and it is coming from the cervical plexus plus C5. The chief value is C4 and is passing anterior to scalenus anterior muscle, and then enters the thorax, lies anterior to the hilum of the lung on either side, running on the lateral aspect of the pericardium covering the heart, and then reaches the diaphragm down here. As you see, the right phrenic nerve is more vertical and shorter in length as compared to left, because left is longer and more oblique, following the left border of the heart, which is more oblique, whereas the right border of the heart, which is more vertical. So the right phrenic nerve is short and straight, whereas the left phrenic nerve is long and more oblique. It is also longer because the left dome of diaphragm is lower and right dome of diaphragm is higher. Pushed up by the lever here, the right dome becomes higher, and pushed down by the heart, the left dome becomes lower, making the left phrenic nerve longer. It is the sole motor supply to diaphragm. Diaphragm has no other motor nerve except the phrenic nerve. It's a skeletal muscle you can use the phrenic nerve to contract the diaphragm, and there'll be diaphragm descend down in deep inspiration to expand the lung, to pull the air into the lung. The phrenic nerve is sensory also to the pericardium and the pleura, mediastinal pleura, and also to the central portion of diaphragm and central portion of peritoneum under the diaphragm. It can carry the pain of pericarditis, can carry the pain of pleuritis, the mediastinal pleuritis, and also central peritonitis. Remember, the peripheral pleura, costal pleura, will be supplied by intercostal nerve, and similarly the peripheral peritoneum will be supplied by intercostal nerve. So intercostal nerve supply the sensation of the peripheral diaphragm, peripheral peritoneum, and peripheral pleura, whereas the sensation of central peritoneum, central diaphragm, and central pleura, mediastinal pleura, is sensory supply by phrenic nerve. Here we are looking at the arterial supply of the thorax region. This is descending thoracic aorta giving pica branches, which are called posterior intercostal arteries, one in each intercostal space. You'll find the first two posterior intercostal arteries are coming from the branches of the subclavian. Otherwise, the third two 12, which is called subcostal, are coming from the descending thoracic aorta. So what about the first two? As I zoom it up, you can see that arch of aorta is giving three branches. This is the brachiocephalic trunk, this is the left common carotid artery, this is the left subclavian artery. Now this brachiocephalic trunk divides into two, which is the right common carotid artery and right subclavian artery. There's a right subclavian artery, there's a left subclavian artery. Actually, subclavian artery's second part on either side is giving what is called as costocervical trunk, coming from second part of the subclavian artery on either side, and that costocervical trunk give us the first two posterior intercostal arteries on right side as well as left side. Otherwise, all the posterior intercostal arteries are coming from the descending thoracic aorta. In fact, the second part of the subclavian artery undercover the scalenus anterior muscle will be giving a branch called costocervical trunk here, and then it is giving superior intercostal arteries on either side. And the superior intercostal arteries which will give the pica 1, pica 2, pica 1, pica 2. When it comes to the veins, you will find thorax drain into the superior vena cava with the help of azygous veins. On the right side, we have one azygous vein. On the left side, we have two of them, called as accessory hemiazygous vein and the hemiazygous vein. The accessory hemiazygous vein will drain the intercostal spaces, which are upper intercostal spaces, whereas the lower intercostal spaces are drained by hemiazygous vein. Now, both of them will be draining into the azygous vein, passing behind the heart at the T8 vertebral level. They cross behind the heart and put the blood into the azygous vein. Azygous vein will put the blood of the right thorax plus additionally left thorax into superior vena cava and enter the superior vena cava at T4 vertebral level. As you remember, it will arch behind the hilum of the right lung to reach the superior vena cava. Also understand that these azygous veins have communication with the inferior vena cava and also the renal veins, the right renal vein, the left renal vein. Let us look at one detailed diagram of this. Understand that there are some veins in the abdomen region called ascending lumbar veins on the lumbar vertebra. This is the right lumbar ascending vein and this is the left ascending lumbar vein. As they reach the thorax region, the 12th rib level, there is a subcostal vein on either side joining them under the 12th rib, and together they will form azygous venous system. On the right side, at the level of T12 vertebra, there is an opening in the diaphragm for the passage of the aorta, and you may find that is also letting pass the azygous vein there. Though the azygous vein is usually puncturing crush of the right diaphragm to enter the thorax. It can be found in aortic hiatus sometime. So this is the azygous vein formed at the lower border of the T12 vertebra and is running in the thoracic vertebra right side, receiving various posterior intercostal veins. As you can see, lower intercostal and upper intercostal as well. Keep ascending up and then it has to drain into superior vena cava. At the T4 vertebral level, it will enter the superior vena cava. And on the left side, the subcostal vein join the ascending lumbar vein, they'll form hemiazygous vein. This is the hemiazygous vein. Hemiazygous vein drain the lower intercostal spaces, whereas upper intercostal spaces drained by accessory hemiazygous vein. Here is the accessory hemiazygous vein which is draining upper intercostal spaces, and both of them will now at the T8 vertebral level cross the midline behind the heart and drain into the azygous vein. Now all the blood is in the azygous vein and then the blood will enter superior vena cava at the T4 vertebral level. Remember, there is a superior intercostal vein on either side. It's formed by the first 2 or 3 posterior intercostal veins. And that superior intercostal vein on the left side drain into the left brachiocephalic vein. This is formed by the union of left subclavian vein from the upper limb and left ventral jugular vein from the head and neck region. So we see the upper limb drain into the subclavian vein, which is joined by the internal jugular vein, which is the head and neck region drainage. Together they form brachiocephalic vein, and left brachiocephalic vein is quite long because it has to cross the midline of the body to enter superior vena cava on the right side of midline, and that is where this left superior intercostal vein is draining. It drains into the left brachiocephalic vein, whereas the right-sided superior intercostal vein drain actually directly into the azygous vein. Let us see a clear diagram for that now. So as we suggested earlier, there is a azygous vein on the right side and hemiazygous veins on the left side. How the azygous veins are formed? You see, there is the ascending lumbar vein coming from the abdomen region on either side and joining the subcostal vein under the 12th rib on either side. As the subcostal vein join the ascending lumbar vein on either side, they form azygous venous system. This is the azygous vein, which is draining all the posterior intercostal vein, even the right superior intercostal vein. As I suggested, superior intercostal vein are formed by the upper intercostal veins on either side. This is the left superior intercostal vein, formed by the posterior intercostal vein number 2 and 3. Then what about the number 1? The posterior intercostal vein number 1 on the left side or maybe the right side drain into brachiocephalic vein. Brachiocephalic vein. So as you see, brachiocephalic vein, maybe the right side or left side, they receive the posterior intercostal vein number 1 on either side. But when it comes to number 2, 3, which is superior intercostal vein, on the left side it will drain into left brachiocephalic vein, but on the right side it is the right superior intercostal vein draining into azygous vein. That is a difference which you have to remember. And what about the hemiazygous veins? Now the upper intercostal spaces, which is 4, 5, 6, 7, 8, are drained by accessory hemiazygous vein, which will then turn and go to drain into the azygous vein, passing behind the heart at the vertebra number T8 there. Similarly, the lower intercostal spaces drain into the hemiazygous vein, which is formed at the junction of the subcostal and ascending lumbar vein. And this hemiazygous vein, which drain the lower intercostal spaces, also drain into azygous vein. And that also happens at the T8 vertebra. If you want specific answer, then T9 vertebra. So this is T8 vertebra and this is T9 vertebra. They are crossing the midline to enter the azygous vein, which will then enter the superior vena cava at the T4 vertebra before the superior vena cava enter the right atrium at the T5 vertebral level. Means the azygous vein is entering superior vena cava 1 vertebra higher to the entry of superior vena cava into the right atrium of the heart. When we talk about the lymphatic drainage of the body, we have to remember that there is a right upper quadrant of the body which is going to drain into right lymphatic duct, whereas the rest of the body will be draining into the thoracic duct. And what do you include in the right upper quadrant of the body? It is the right upper limb, right thorax, and right side of the head and neck region. As you can magnify here, you will notice that it is the right upper limb lymphatic drainage going into the right subclavian trunk. And when it comes to the right thorax, it will go into right bronchomediastinal trunk. And when it comes to the right side of the head and neck region, it will be going into the right-sided jugular trunk. And these 3 lymphatic trunks, they will be joining the right lymphatic duct. Otherwise, body below the diaphragm will be draining into the cisterna chyli in the abdomen, which will collect lymphatic drainage of the lower limb and the abdopelvis into cisterna chyli. And from the cisterna chyli starts a thoracic duct, which will be then draining the lymphatic drainage of the thorax region, upper limb, and the head neck region, which is shown there. Let us look at one more diagram for the same purpose. As I am suggesting, the right upper quadrant of the body has the right lymphatic duct, which is receiving 3 ducts itself. Let's zoom this area. The head and neck drain into right jugular trunk, and the thorax drain into bronchomediastinal trunk of the right side, and the upper limb drain into right subclavian trunk. They all join to form the right lymphatic, and the right lymphatic duct will drain into right venous angle, which is called right jugular subclavian venous angle, meeting point of internal jugular vein and the subclavian vein. It is also the beginning of the brachiocephalic vein. Similarly, on the left venous angle is the opening of thoracic duct. Thoracic duct, which comes in the thorax and then drain into the left venous angle, is obviously receiving left jugular trunk, left subclavian trunk, and left bronchomediastinal trunk. And then the lymphatics drain into neck veins before the neck veins drain into superior vena cava and the heart. So lymphatic must enter the vein before the veins enter the heart. Let us follow the details of thoracic duct now. As I suggested, the thoracic duct is beginning or continuation of the cisterna chyli in the abdomen region in front of L1, L2 vertebra. So at the level of L1-2 vertebra, you have the cisterna chyli, which has received all the lymphatic drainage which is below the diaphragm, that is the abdo-pelvis and lower limb. And after that, it is passing the aortic hiatus at the lower border of the T12 vertebra to enter the thorax and become the thoracic duct. Let us zoom this area now. So at the level of thoracic duct, entering into the aortic hiatus, which is an opening behind the diaphragm, is for the passage of the aorta. So it is the descending thoracic aorta, which is coming from the thorax and enter the abdomen at the aortic hiatus, T12 vertebral level, opening behind the diaphragm, which is also letting pass the thoracic duct and azygous vein sometime. Sometime the azygous vein will pass through aortic hiatus in front of T12 vertebra to enter the thorax. In that case, the thoracic duct is sandwiched between the 2 vessels. the aorta on the left side and esophagus vein on the right side. Now this thoracic duct is running on the right side of midline for a while, and at the level of T5 vertebra, it will turn to the left side. Let us zoom to that level now. So the thoracic duct was running on the right side of midline at the T5 vertebral level. It is going towards the left side because it has to enter the left side neck veins. It will ascend up into the thoracic outlet and go into the neck region, reaching the C7 vertebra, and then it will empty into the left venous angle, which is the left jugular subclavian venous angle, beginning of the left brachiocephalic vein here. Talking about the breathing movement, respiratory movement, there are upper ribs which are involved in pump handle movement and the lower ribs which are involved in the bucket handle movement. When you say pump handle movement, you are going to pump the water, and in that process the sternum is moving anterior posterior. In that movement the upper ribs are moved anterior and posterior, and you are increasing the anterior posterior diameter, which is between the vertebra and the ribs. In that process, the lungs are going to expand anterior posterior. On the other hand, like you raise the bucket handle, you are going to increase the transverse diameter. The lower ribs are going higher, and as they go higher, you are increasing the transverse diameter. The lungs will expand transversely like this. So as the lower ribs are elevated, as during respiratory movement, the transverse diameter is increasing to expand the lung in that dimension. Now, the chief muscle of inspiration is diaphragm. Let us talk about the others as well. So, when we are using the skeletal muscle diaphragm, which is the chief muscle of inspiration, the diaphragm descends down during deep inspiration, and the vertical diameter of the lung will increase, and you can pull more air inside the lung. Inspiration. If you want to do forceful inspiration, then you can use other muscles also, like the external intercostal muscle and the scalene muscle. So scalene muscle and the external intercostal muscle help us in forceful inspiration. Also, we can use the internal intercostal, which are chiefly the muscle of expiration. But if you are talking about interchondral portion anteriorly, then they are accessory muscle of inspiration. Otherwise, they are muscles of expiration. Let us look at the muscles of expiration as well. Now, though expiration is elastic recoil of the lung and pushing the air out, you can do forceful expiration using anterior abdominal muscles, like you have the external oblique muscle, internal oblique muscle, transverse abdominal muscle, like you are coughing or you are straining for defecation, urination, or parturition, the labor. Then you use these muscles, which can increase the intra-abdominal pressure by doing forceful expiration. They are the anterior abdominal muscles. And as I suggested, the external intercostal are for inspiration, internal intercostal are for expiration. Especially the fiber which are lateral. Interosseous means between the ribs. The lateral fibers are for expiration, forceful expiration. Whereas the anterior intercondral portion are for deep inspiration. Here we are talking about a patient having pleural effusion and we want to remove it, so we have to do it at the scapular lines or the axillary lines. The muscles which we are going to puncture, we have to discuss, and it may be the serratus anterior, then the three intercostal muscles, which are external intercostal, internal intercostal, innermost intercostal, and then you have to puncture a pleura also. Which pleura you will be puncturing, the parietal or the visceral? Let us find out. So this is our needle which is going, and it is going above the rib here to aspirate the pleural effusion. Why we go above the rib? Why not below the rib? Because below the rib we have some structures, and they are the vein structure going down. Vein goes down. Vein goes down is the arrangement vein, artery, nerve. Intercostal vein, intercostal artery, intercostal nerve, superior to inferior. So this vein goes down. You are not supposed to damage. It is better you go above the rib rather than going below the rib. Now, as you go above the rib, to avoid injury to the neurovascular bundle in the costal groove at the lower border of the rib, you are puncturing some structures, some muscles, like this is the very first one, serratus anterior. The serratus anterior muscle take origin from the upper 8 ribs. As it is taking origin from the upper 8 ribs, you are going to puncture this muscle, the first one, and after that you are puncturing 3 intercostal muscles. Namely, there is the external intercostal muscle, which you can show here, and then deep to that is internal intercostal, which you can show deep to that, and then there is the innermost intercostal, which is deep to the neurovascular bundle here. And after puncturing the innermost intercostal, you are puncturing a fascia, endothoracic fascia, which is actually fused with the parietal pleura. So since the parietal pleura is fused with the endothoracic fascia, you will puncture them simultaneously, and then your needle will enter the pleural space where you have pleural fluid. You can aspirate that. You are not supposed to puncture the visceral pleura, because if you puncture the visceral pleura, you will puncture the lung and air will come here. It will become hydropneumothorax. That you don't want. So you cannot puncture visceral pleura. You just puncture the parietal pleura, and then it is the pleural effusion fluid you can aspirate from here. Now, in case of a block, which is required when there's a multiple fracture of rib, you are supposed to push your needle below the rib, because you are going to block the intercostal nerve here. VAN, van goes down, van goes down. But these are the collaterals. They are not inferior. They are superior to the rib. So what is the message here? Message is, when you are having fractured rib and you are doing intercostal block, you are obviously supposed to do it below the rib, but also above the rib. Why? Because there are some collaterals which are given by intercostal neurovascular bundle, and you must block them. Because if you don't block the collateral, then the pain will persist. So we have some neurovascular bundle above the rib also. Yes. So when I was doing the pleural aspiration, then I will be damaging that. Yes, you are damaging that, but you have to decide whether you want to damage the collateral branches or the major branches. So you want to push the needle below the rib or above the rib. And in pleural effusion, aspiration, it is preferable you go above the rib. You will damage some neurovascular bundle, but they are small. You are not going to damage the bigger neurovascular bundle. So the aspiration done above the rib and block is done below the rib, but you should also additionally block above the rib. If intercostal block is asked, what is my first answer? Below the rib. Now, we are looking at the apex of the lung, which is covered by a membrane, which is called as a suprapleural membrane. It is a modification of the scalene minimus muscle. There is a scalenus anterior, medius, and there's a minimus also. It is modified and it's a degenerated tendon, suprapleural membrane, or called substance fascia, on the apex of the lung, attaching to the first rib and also the transverse process of the C7 vertebra there. Let us magnify this now. So as you magnify this, there is a suprapleural membrane which is called substance fascia, which is a degenerated tendon of scalenus minimus and is attaching to inner border of the first rib and the C7 vertebra transverse process, and it is over the apex of the lung. Now, apex of lung is covered by the cervical pleura, which is then covered by this membrane, which is suprapleural membrane. It is going to separate the subclavian vessels from the apex of the lung there, and this is touching to first rib and also C7 vertebra transverse process. And when you're talking about the first rib posterior aspect, you will find some of the neurovascular bundle passing there. You can remember Schwann goes out, Schwann goes out means what is the most medial? It is a sympathetic chain. And what is lateral to that? V for vein, first intercostal vein. And A for artery, the posterior intercostal artery 1, superior intercostal artery. And what is the N for? N is the nerve, which is the ramus of the T1. It is thoracic 1 nerve, so ventral ramus of the T1. So Schwann goes out, Schwann goes out. Actually, we have learnt vein goes down in all the ribs. But here, the vein goes out in the first rib. Related to the neck of the first rib, posteriorly, and the apex of the lung anteriorly. So anteriorly is the apex of lung, posteriorly is the neck of the first rib, sandwich between the two. Sandwich between the apex of lung and the neck of the first rib is Schwann structure going medial to lateral. And what is running on the superior surface of the first rib? If you remember, we have discussed the subclavian vein, which becomes axillary vein. This is the subclavian artery, which become axillary artery, sandwiching the tendon of scalenus anterior muscle inserted on inner border of the first rib. And what is this insertion of? That is scalenus medius. Scalenus medius are inserted on superior surface of the first rib. If you remember, we had the interscalene triangle, and in the interscalene triangle, we could block the third path of subclavian artery on the superior surface of first rib. You can also block brachial plexus there. If you have multiple fractures in the upper limb, you were putting some nails and plates and the wires, and you have to block it here in the posterior triangle, interscalene triangle between the two scalene muscle. You have to go lateral to the scalenus anterior muscle there.